Good morning, everyone. We're going to be starting soon, so if you can make your way into the room, find a seat. There are not assigned seatings this morning, so just find a place that feels comfortable to you.
Good morning. Good morning. Good morning. Good morning. Good morning. My name is Louise Ivers, and I'm the Faculty Director of the Harvard Global Health Institute, your hosts for today. I'm a professor at Harvard Medical School and at Mass General Hospital, and I'm delighted to be here and thank you all for joining us. We're gathering at a time of profound strain on the systems and the institutions that global health has depended upon. 2025 saw the largest contraction of funding for international development, not just by the United States, slashing by at least a half, but also by France, Germany, Japan, and the United Kingdom. And it's not just about the financial aid or the funding. Multilateral cooperation is being rejected in many corners in favor of isolationism. The voices calling for retreat from global solidarity are loud, often violent. Violent words and violent actions have become, in some ways, a norm, a political norm, but not for all of us. Here we all are, researchers, clinicians, scientists, students, policymakers, and practitioners from far beyond Harvard, from dozens of countries, dozens of communities together in this room, online, 3,000 people watching, to think carefully about what comes next through collective action. This is the fourth Annual Global Health Symposium hosted by the Harvard Global Health Institute. And when we designed this year's theme, which is Global Health Forward, Strength Through Innovation and Collective Action, we did not choose those words lightly. Forward is not a platitude. It's a deliberate insistence that despite everything pressing against us, we have a responsibility to move. Today, we'll examine some of the hardest questions in global health right now. How should priorities be set when resources are very scarce? How do we build health systems that are genuinely prepared for emergencies, not just in theory, but in practice, and in the communities most at risk? How do we train the next generation of health workers in ways that strengthen the system, not take from it? And what does accountable governance look like across the extraordinary diversity of regions and political contexts that make up our world? After our keynote address this morning, our day will move through three major panel discussions, each hosted in partnership with our colleagues across Harvard, for which I'm very grateful. The T.H. Chan School of Public Health, Harvard Medical School, Harvard Law School, and the David Rockefeller Center for Latin American Studies. And these collaborations are not by chance, they're by design. Advancing global health equity won't live within a single discipline. It requires the tools of clinical medicine, public health, economics, ethics, law, design, political science, engineering, and so on. We'll hear today from health systems leaders in Africa and Latin America. We'll examine workforce training models that are strengthening health systems from Rwanda to rural America. And this afternoon, we'll be joined by Evan Wong, the National Youth Poet Laureate of the United States, who will offer a poetry reading. And I want to say something about why that matters and why it belongs in the middle of a global health symposium. The data and the policies that we'll discuss today represent real people. Behind every statistic of vaccine coverage or workforce shortage or emergency preparedness gaps, there are communities with histories and futures, with knowledge and capacity, with enormous resilience in the face of systems that too often have failed them. Poetry reminds us of that. It resists the detachment that technical language sometimes encourages. We need both rigor and humanity to do this work well. I've spent much of my career in places where the gap between what global health promises and what it delivers is stark. But I have also seen what happens when that gap closes, when resources reach communities, when health workers are trained and supported, and when those closest to the problems are leaders of the response, and when systems hold. And what I do know is this: the path forward requires both innovation and accountability. It requires us to be honest about what is failing and to be specific about what must change. And it requires collective action, not as a slogan, but as a practice. So let us keep showing up, as all of you have done today. Let's bring expertise to bear and refuse to accept that suffering at scale is inevitable. Thank you for being here, and let's get to work. It is now my distinct pleasure and honor to welcome Dr. Sonia Nishtar to the podium, the Chief Executive Officer of Gavi, the Vaccine Alliance, and one of the most consequential voices in global health today. As a medical doctor, Dr. Nishtar has built an outstanding career over 30 years as a national and a global leader. She served as a senator in her home country of Pakistan, as Special Assistant to the Prime Minister on Social Protection and Poverty Alleviation, as a federal minister with responsibility for the Ministry of Health. Dr. Nishtar has fulfilled several leadership positions in civil society, in international organizations, and founded a health reform organization think tank in Pakistan. She's co-authored dozens of influential papers and books and published in leading newspapers. As a graduate of Khyber Medical College, Pakistan, and also King's College, London, she has received numerous international awards, and in 2020, the BBC named her among 100 inspiring and influential women around the world. We're absolutely honored to have you with us today, and I welcome you to the podium. Thank you.
Good morning to all of you. Let me begin by saying how truly honored and deeply grateful I am to be here. And thank you, Louise, for the very kind invitation. Thank you to the Global Health Institute for organizing this symposium for the 4th year running. I think, Louise, you painted a very appropriate and a sobering picture of where we stand, and I don't think I can add to that, except saying that we are living in truly unprecedented times. But I so liked the foreword in the subtitle of the symposium, because I think we are where we are and we now need to think about where to go from here. and to take the remedial action that the world so desperately needs. I decided not to go into the definitions of global health because that would have taken me half an hour, and I'm very practical. I like to be solution-oriented. But how do we get to the stage where we are in terms of the architecture of global health? And if you look back into history from the colonial times, there was a time when we used to talk about tropical medicine. Then came the era of international health with a focus on technical assistance. Then was the decade of the Alma Ata Declaration and a focus on primary health care, which was followed by the movement of structural adjustments. Subsequent to that, in the 90s, there were a number of different things that moved together. There was a focus on product development partnerships, some very influential product development partnerships, which did extremely well in reducing mortality and morbidity in some of the most disadvantaged settings of the world. At the same time, the HIV and AIDS emergency came up, and several instruments were created to combat that. And of course, at the same time, things started shifting. So from the year 2000 onwards, there was a proliferation of global health institutions, large global health institutions. And at the same time, the world came together. The then G8, which had a lot of fiscal space, created a compact called the Millennium Development Goals. And all the developing countries aligned behind that. I worked in Pakistan then, and I saw how all developing countries aligned behind the Millennium Development Goals, the time-bound outcome-based goals. And subsequent to that, a number of institutions were created. Gavi was created in 2000. The Global Fund was created in 2002. PEPFAR was created in 2003, and a number of other very large bilateral instruments were created by the United States around the same time. Fast forward 15 years, and then comes the era of the SDGs, where there was an increasing realization to the importance of systems development. And now we are 4 years before the culmination of the SDGs at a crossroads where things have dramatically shifted. There always was a realization that there will be a new era of development after the SDGs, but it has just been preponed in the context of where we stand today and the very eloquent rundown that Louise gave just a moment ago. So if we look at from tropical medicine to the SDGs, I think as a starting point, we need to be very proud of ourselves because a lot has been achieved. During this time, and I'm not saying that this is by any stretch of imagination, that this was the result of the institutional architecture, because there were several technological and therapeutic advancements, the social conditions improved, per capita income improved. And as a result of that, for all these changes, we gained 10 years in life expectancy. There was a 60% reduction in under 5 mortality. There was a 40% reduction in maternal mortality. 75 million deaths during this time frame were reduced due to vaccination alone. Another 25 million HIV/AIDS-related deaths were averted due to the countermeasures in that space, and 13 million malaria deaths have been averted during this time frame. So I think there is reason to be there's a reason to celebrate what was achieved, notwithstanding the shortcomings of the global health architecture, because you will hear a lot today and going forward about the shortcomings of the global health architecture and the need for reform, and we should completely stand behind that. But we should also not forget that the architecture we developed, the investments that we made, have really yielded dramatic results. And it is very important that in any new structure that we create, these gains should not be compromised. That realization is very important because we are seeing the beginnings of that. Last week, the OECD came up with a report, and the report basically showed that there has been the single largest reduction in ODA when you compare 2023 with 2024. It's the single largest reduction in ODA, 23.1%. And early outcome-based data is showing that the trend in the reduction of under 5 mortality is sadly beginning to reverse. So we really have to act, and we have to act quickly to protect the gains that we have so painstakingly made over the last several decades. In order to make change, we have to read the landscape, and we have to read the context. And I think there are some important changes that we must bring to bear. The first change is that there is now an ideological decision to reduce ODA, official development assistance, and to scale down official development assistance. And this is not something that is related to the rapid shutting of the doors of USAID. This was something that was on the anvil for a very long time. At least as far as 6 to 7 years ago, we saw development agencies absorbed into ministries of foreign affairs. Even as a new CEO of Gavi 2 years ago, when I took a round of all the donor countries, I could see each one of them saying, we have decided to cut back on ODA because we have competing priorities, because we have to cater to internal migration, because defense spending is now an imperative. And of course, conflicts are increasing, and this situation will further perpetuate. So the ODA decline is something that is real, it is happening, and it is not confined to the United States. It's a worldwide trend. Even countries with surplus budgets are telling me we have taken a decision to cut back ODA. So that's the one change. The other change, and here you will see a silver lining, there is a movement to promote national sovereignty. So if you go to Africa and if you speak to heads of state, they will tell you, we want to be health sovereign. And for us, health sovereignty means the ability to indigenously mobilize resources and the capacity to accrue the benefits of those domestic resources to our populations in terms of primary health care, in terms of basic education. And we are willing to invest the resources that are needed. And we are willing to step away from ODA, but we need a fairer trade deal. We need fairer terms of engagement in the global system. And that's another movement that is playing out. And the third movement which is playing out, and my colleague Yonane is here, some of us are at the forefront of these debates and discourses and institutional restructuring, because there is now a very clear realization that the international development architecture, the international global health architecture needs to change, just needs to change. It is expensive, it is duplicative, it is fragmented, there are competitive behaviors, there are mission creeps, and we cannot afford it anymore. So I think when we talk about reform of the global health architecture, we need to bring to bear these three realities. The systemic decline in ODA, to the extent that it is now irreversible. And I'm not saying this is the end of ODA. There still will be an appetite to spend ODA in fragile settings and in humanitarian settings. But the whole-scale mobilization of ODA, which was the norm in the era of the MDGs, is a period that's over. Secondly, the health sovereignty movements. And thirdly, the appetite within the system to do something radical and to do it fast. So 2 years ago, when I came in as a CEO, I could clearly see the writing on the wall. And I began a reform of the organization of Gavi, which is called the Gavi Leap. And I'll talk about that a little later. But I also proactively engaged in the discourse on the reform of the global health architecture with many of my other colleagues. I think it is very important that we come to an understanding, a collective understanding on what we mean by reform of the global health architecture. What are the levers available to us? And And in order to do that, we have to be clear about the objective first. Because the objective and the principles. The principles, of course, drive the objective, and then the objective drives what the process should look like and what agencies are in scope, because we're talking about a plethora of agencies. The objective, as I said, can be different depending on the vantage point. And I'd like to outline 3 objectives in 3 different buckets here, but I have to be mindful of time. So how much time do I have? 24 minutes? Okay. I can take the whole 24 minutes? Okay. I'd like to keep some space for questions and answers. So when you don't have a scripted speech, you tend to go off time. So I want to talk in 3 different buckets. And I want to re-emphasize that the objective can be very different. The process and the definition of agencies that are in scope and the timelines can be very different depending on your objective. And as I said, I'd like to talk about 3 in particular. One objective can be addressing the fragmentation, duplication, and the issues that exist at a country level. And I put on my hat of a former government official in Pakistan. How does a Minister of Health perceive the global health architecture at the local level? It's extremely fragmented. You have 10 to 15 UN agencies, you have Gavi and the Global Fund, you have a number of different philanthropic organizations, you have the World Bank, you have 3 to 4 regional development banks, you have a number of bilateral agencies, each one of them with good intentions, each one of them wanting to support, but each one of them has unique demands of the ministry. They want they have their own grant cycles, they have their own accounting systems, they have their own procurement systems, they have their own guidelines. Each one wants a separate audit. Each one has different country teams. Each one wants a different set of meeting with you, and each one of them wants a different institutional arrangement. So from morning to evening, you're going to the committee, the governing committee of Gavi, to the management committee of the Global Fund, to the steering committee set up by the then USAID, to the technical committee of DFID, and so on and so forth. It's huge fragmentation. And each one of them has a separate task. If you go to a primary healthcare center in any developing country, under the same roof, you will see that the contraceptives are provided by UNFPA with their own supply chain, with their own procurement systems, with their own HR personnel, with three levels of institutional hierarchy. The vaccines are provided by Gavi. The TB drugs are provided by Global Fund and 4 or 5 other agencies as well. RUTF is provided by UNICEF. RUSF is provided by the World Food Program. The list can go on and on. So depending on how much the child weighs and the level of malnutrition, you go either to the World Food Program kiosk or you go to the UNICEF kiosk. These things are duplicative. They pose a huge administrative burden on ministers and officials, and this really needs to change. If we as global health actors, and I put back my international hat, if we are serious about remedying the failings of the global health architecture, this is the one separate objective we must have. And this has nothing to do with the conversation of how we're going to reform institutions in Geneva and New York and in Washington. This just requires a consensus by the donors to cede their authority, to cede their power to the local level, and to put all their resources at the disposal of governments with bolstered checks and balances. And I must re-emphasize, with bolstered checks and balances. And this is one separate objective. What is the second objective? The second objective is regarding, and by the way, on the first objective, we are calling this in our own parlance as merger at the last mile. we're saying it is not just reform of the global health architecture, it should also be reform of the local health architecture with its very different process, very different objectives, very different stakeholders, but very strong principles and an alignment by the donor community. So that's number one. The second objective is, what are you going to do about issues at the global level? There's a proliferation of organizations, and the way we do our fundraising, we are competing against each other. Let me be quite honest and candid here. There are lots of mission creeps and competitive behaviors, and there are no incentives to stay in your lane, which is why when I'll talk about the Gavi leap later, our own reform process, but one of the principles of the Gavi leap is focus mandates. Because currently there are no incentives to remain focused on your lane. There is an incentive to proliferate because we all compete for resources. And there is a way to remedy the duplication and fragmentation, but we have to be very brutal about that, and we have to be, there has to be an independent process, analyzing and then coming to a consensus. One part of, and of course as part of that equation, there's huge potential to merge entities, sunset entities, and to come up with a smaller, more agile ecosystem where entities have very clear mandates and a disincentive to expand their mandate, and a mechanism to bring agency heads together in a coalition which is institutionalized. And this is one of the recommendations that I gave in a Lancet paper which was published in January. It was called Reform of the Global, it was called the Global Health Leap, an urgent call to action. But as part of that effort, I think there are some hard questions that we must address, because those hard questions are often sidestepped. One of those hard questions relates to the definition of ODA itself. Because we lump development assistance with the assistance that should finance global public goods. Global public goods such as global health security, pandemic prevention, norms and standards, cross-border transnational regulation. And these are the kind of global public goods that benefit every country of the world. And every country of the world should support and pay for the maintenance of this ecosystem that serves all of us. But aid is something else. Development assistance is something else. It's not the same as the financing of global public goods. And there are examples in the world. For instance, the airline regulator, as far as I know, is maintained by contributions that come from every country. And we need to develop a similar system in global health to support global public goods and mandates such as pandemic prevention and response, and norms and standards and regulation. And of course, aid and development is a different matter. That's one hard question that we need to address. The other hard question is about the competitive behaviors. Because back in 2024, when MPOX struck, we literally saw regional and global institutions competing with each other. And there needs to be clarity on who does what. Thirdly, and in terms of putting the hard questions on the table, does reform of the global health architecture just mean the global health institutions, or are we going to take a one health approach? Are we going to put development intermediaries in the mix as well? That's something else we need to ask ourselves and address. What about fragile settings? As ODA is declining, are we going to abandon fragile settings, and how are we going to protect the fragile and humanitarian settings, and what kind of new risk appetites do we need to develop to cater to those? What about missing competencies? Because we take it as a given in our current discourse that we need to shrink the global health architecture, but there are some missing competencies within this space as well. Some of us were at the Munich Security Conference in February. The entire discussion of the Munich Security Conference from a global health vantage point was centered around the new bio threat centered on AI. So AI poses bioterrorism threats of a kind that people like us, are even beginning to understand the implications of. And we need to develop institutional competencies within the global health architecture on the global public good side to be able to counter that. What about NCDs? 1 in 3 people in the world has high blood pressure, 1 in 4 has diabetes, and obesity is rampant. NCDs are on the rise. But the way the global health architecture is currently designed does not cater to NCDs. You need to work with the private sector to avert threats, and we have no mechanism, institutional mechanism to do that. When I was the chair of the High-Level Commission on Non-Communicable Diseases, it took a huge drama for us to have a 5-minute interaction with the Cokes and Pepsis and McDonald's of the world. Huge drama, in-camera conversation with them for just 5 minutes. The world does not have the capacity to sit with these actors because they have solutions for NCDs. We're not even talking to them. So there are these centered on the global regional tensions and the role of AI in bioterrorism and the possible support for fragile settings and the missing competencies and so on and so forth. There are a whole host of tough issues that need to be put in the table when we talk about design of the global health architecture. And my worry is that although we strongly believe there is a consensus that the World Health Organization is the right lead agency to be shepherding these conversations, but some of us worry because the member state process inherently is such that you are left with consensus on the lowest common denominator, and some of the tough issues do not come to the fore. And finally, the third bucket that I wanted to talk about was what do you do in the new global health architecture? What do you do with these institutions that have delivered wholesale impact on the ground? Institutions like Gavi and the Global Fund. I mean, in humility, I'd like to say Gavi as an entity has vaccinated over 1 billion children, saving 20 million lives, accrued $52 of economic benefit for every dollar invested in Gavi. We work at a 3% operating cost. And I again want to say in humility, we're the poster child of what development should be in the future because we show countries the pathway to transition and for countries to exit. And our sister agency, the Global Fund, delivers similar impact in 3 disease domains. Massive benefits to the humanity. And as we go forward, what is the future of organizations that deliver impact, wholesale impact? Gavi and the Global Fund are 2 of them, but there are smaller product development partnerships as well. How are we going to design the transition plans that will allow countries to take over responsibilities without creating the adverse effects that the sudden pullout of USAID did? My apologies for raising this, but it is a fact. We need to prepare well-designed transition plans. So these 3. I just wanted to bring to bear the complexity of the nature of the discourse, the complexity for planning and execution, and the need for clarity and objectives. You want to make a change, to summarize, you want to make a change at a country level. It's a different problem you're solving for. It's a different discourse, and the stakeholders are different, and the process has to be a standalone process. You want to make change at the global level. You want to simplify the architecture. The WHO is the right avenue. But you cannot have a standard member state diplomatic process and end at the end of 2 years with nothing but text that says very little. You have to put the hard questions at the center of the equation. And thirdly, then it is the future of the development intermediaries that have delivered huge impact And now is a question of how do you transition responsibility to countries. So this is the context in which we designed our own reform called the Gavi Leap. And with the Gavi Leap, we did several things, because what we wanted to do was to design an organization which was fit for a future global health architecture. We've scaled down by 1/3. We've made ourselves far more efficient, accountable, transparent, with tighter controls, with far more transparency, with far more checks and balances, digitizing our key processes, and all that has come to fruition in the last 2 years. We're transitioning many responsibility to countries, and one of the key things that you have to do when you talk about country transitions is to give them authority and responsibility. You cannot be talking about country transitions and still hold the resources in your hand. And that was a difficult, very difficult thing to navigate with a lot of opposition. But we have and will continue to cede authority and transition decision-making responsibility to countries. We've radically simplified our country operating model. And one of the things that we feel as an organization is very important, that you listen to the countries that you are meant to serve. We exist to serve countries in the South. You must listen to them. So our modification of our country operating model, the radical simplification that we've adopted, is the direct result of what I heard within the first 10 days of assuming office. We've been at the World Bank annual meetings earlier this week and are going back again this afternoon, which is why I apologize. I'll have to leave a little early. And yesterday we were telling them that health sovereignty is a big movement there. Africa wants to be health sovereign. They want to manufacture their own vaccines. They want to manufacture their own medicines. They have a goal. They want to achieve that goal. At Gavi, we put a subsidy instrument, and then we went back several times and listened to them. They wanted modifications in that subsidy instrument, and we've gone back and made those modifications. So just to end, as I look at the watch, I realize I've taken more time than I ought to have. Yes, we are talking about reform of the global health architecture, and yes, there's a collective conversation about objectives and about goals and about processes and about collaboration and engagement, but that should not preclude us all from making the changes within our own organizations that will make us fit for the next 15 years after the SDG, starting now. We've embarked on that journey. And I'm really grateful to all my colleagues who have been such an important part of that transformation. And I'm grateful to our board for their support, and grateful to all the stakeholders and academic colleagues who have supported in this effort. So let me stop here and hand it back to you, Louise.
Thank you. We do have time for some questions, so thank you for saving time for that. Maybe we're going to go first to our online audience. I know they're always really keen to engage, and we have Princess who's helping to manage those questions. And if others in the room have questions, please do raise your hand, and then we'll be having you use those microphones on your table. So thank you, Princess.
Thank you so much. We have one question online. Incidents like the recent HIV outbreak in Pakistan suggest that enforcement alone isn't enough. What systemic factors allow basic safety protocols to repeatedly break down, and what kind of accountability model would prevent this from reoccurring?
Shall we take a few?
Yeah, let's take a few. Jessica. And would you mind introducing yourself briefly? Thank you.
Hi, I'm Jessica Haber. I'm at the Center for Global Health with Louise. So I really appreciated your comment about the competition that we have amongst each other, which I think is real and really stifling. You mentioned the need for consensus and trying to find a way forward and not seeing our work as a zero-sum game in many ways. And I wonder if you could comment some more on who do you think should lead that consensus effort? Because that itself, I think, could be an important starting point, but also a stumbling block. Thank you.
And do we have another question in the room? And then we could maybe... shy audience warming up. We'll maybe start there, please.
So in Pakistan, HIV, the resurgence, as you know, prevention is a societal responsibility. And of course, the health system has a very important role to play by reinforcing the preventive behaviors, and we simply fail to do that. That's a simple answer to that, and that should teach us a lesson. On the consensus efforts, as I mentioned, the discussion on the reform of the global health architecture is not a nice and fluffy conversation on which 200 member states of the world are going to weigh in and we are going to come up with the lowest common denominator. I don't think it should be a traditional member state process. Many of us do believe that the World Health Organization is the right institution to lead that. But the WHO Director General has a lot of authority, moral authority, and power to design processes that are fit for the outcome that is to be achieved. And I believe that it is entirely possible for the World Health Organization Director General to put in place an independent process and then make the findings and the recommendations of that independent process seriously binding, and then shepherd the process of reform, because this is not going to be an easy sell. Different countries have their pet institutions and have a disincentive to see those institutions merge or disintegrate or scale down or acquired, but this is something that needs to be done. If we want to tidy the global health architecture, if we want to scale it down, if we want to make it nimble and fit for purpose for the next 15 years, for the next decades to come, some tough decisions have to be made. And it is only the World Health Organization that has the moral authority to shepherd this process, and they need to be very, very courageous in this effort.
Dr. Barnos.
That was really inspiring, and I hope this question is not too granular. It was wonderful to hear about the transition of responsibilities and authority to local countries, to local governments within countries. And I had a question about vaccination, and specifically the HPV vaccination. If countries decide based on evidence, for example, to vaccinate older adolescents, to vaccinate boys, is this something that Gavi would be able to support?
It's a question of resources. You see, it's a question of resources, because we've recently done our replenishment, which, as you know, is in our parlance the word for fundraising for our next 5-year strategy cycle, which kicked off this January. We had an ask of $11.9 billion. We were able to secure 10, which in the current environment is a very good outcome, and there were many new donors, which was a very pleasant surprise. But we are short, 2 billion short of our target, and we had to make many adjustments to our program. So it ultimately, the short answer to your question is yes, but it's a question of the availability of resources, and we are currently fine-tuning and slightly curtailing our programs so that we don't water down our ambition, but still deliver with recasted programs. Hopefully, when resources are available, it's a different matter.
We have another question online, and then I think we would have time for one more in the room if anybody would like to raise their hand. Let's go there first, please.
Oh, thank you very much, Sonia. Claudia Peixoto from PAHO WHO. And thank you for your reflections, but it's something that has been resonating in my head when you talked about health sovereignty, because if there is one of the effects of the pandemic, I'm talking on the aftermath, has been the reduction of immunization rates, and there are new, let's say, even sickness that have been already eliminated are resurging. So there is this, and this is happening. How is it compatible that you have this appetite for health sovereignty versus this decrease in immunization rates, when immunization is one of the basics of primary health care, for example. Thank you so much.
Thank you. And the last question, Princess from online.
Yes, so the question is, as you mentioned, we are all competing for funds, but how can local NGOs and existing local civil society organizations increase their impact?
Sorry, could you come again? How could
local NGOs and local civil society organizations increase their impact?
Okay, so very quickly on the question from colleague from PAHO on the resurgence of diseases that were once eliminated in geographies and its interplay with the health sovereignty movement. So the health sovereignty movement is coming primarily from the African continent. And of course, there are problems of vaccine information there as well, but we do not see a decrease in appetite. We don't see a decrease in demand. In fact, there is so much demand for vaccines from the African continent that we are unable to fulfill that demand. The malaria vaccine is a case in point. We had the fastest rollout of the malaria vaccine in the history of vaccination ever. 25 countries adopted it in 2 years. And there's so much demand that we are unable to fulfill that. The problem of resurgence of eliminated diseases in geographies is coming from the north. I was speaking at the UK Parliament, and the first thing the chair said to me was that today is when we lost our measles-free status. You switch on the television in Canada and you're hearing about measles outbreaks. In your country, this is happening again. And the determinants of that are things that you're well aware of. Let us not go there. But to be very honest, after the pandemic, we seem to be suffering from a collective amnesia because the pandemic brought the world to a standstill. It inflicted pain on this planet of a magnitude that we have not seen before. And by every measure, we should be all rallying up to gear up to protect ourselves from the next one and to make sure that we have the response measures in place. But here we are at the World Bank Spring Meeting week trying to make a case for pandemic-level surge financing. And that, to me, indicates that we all suffer from collective amnesia. But thank you for that important question. On the role of local NGOs and civil society, so the civil society plays different roles. You know, the civil society sometimes has roles that are very different. At times, it needs to advocate. At times, it needs to be an honest voice, and at times it has to be in a contractual relationship to execute on the ground. And it depends on the color and flavor and construct of the civil society group. Not all civil society groups are alike. They have different mandates, they have different missions. Some of them cast themselves more as expert groups and technical groups that are an honest voice, that advocate, that lobby to governments, particularly in the developing countries on thematic areas. And then there are others that mold themselves more as delivery agents and then work. It depends on how you want to position yourself. But from our work in Gavi, we know that the civil society plays a very important role. The civil society sits on the Gavi board. They're advocacy partners for us. They help us mobilize resources, and they help us deliver on the ground in very different settings where governments are either unable to operate or are unwilling to or are not allowed to. And that's where the civil society really comes in. It becomes really very useful for us. And I have enormous respect for the work they do.
Thank you, everybody, so much. Thank you so much, Dr. Nishtar. It's been an honor to have you here. We really appreciate you and your words. Please join me in thanking our keynote speaker.
Thank you. Thank you, sir. I'll be in touch.
Thank you, Dr. Nishtar, for your very practical reflections. It's really an honor to have your voice framing the conversation that we're going to have today. Good morning, everyone. My name is Carolina Lucy. I'm the Associate Director of Programs here at the Institute. It is my pleasure to guide you today through the programming. We're going to start today with a very timely conversation around priority setting, solidarity and global justice when resources are scarce. This session is a collaborative effort with our partners at the Department of Global Health and Population at the School of Public Health. And to open this dialogue, we will welcome Ole Norheim, who is the Mary Saltonstall Professor of Ethics and Population Health here at the School of Public Health. Professor Norheim, please join me here. Thank you.
Thank you so much. And I think this panel will follow very nicely after Dr. Nishrat's very thought-provoking thoughts and talk. So I want to reflect a little bit on the moment we are in now as a global health community. And I make 3 points, and I'll start with macroeconomics. The latest Financing for Sustainable Development report from 2026, the UN Interagency Task Force, concluded that the poorest, worst off countries are in a financial squeeze. Structurally low tax revenue. It hasn't changed for 20 years almost. Decline in official development assistance, as we have heard a lot about here. And trade and investment disruptions. And the latest war, of course, in the Middle East has made it even worse. So on the ground, clearly, budgets will be cut. And that's what we will discuss in this panel, and what countries can do and what global actors can do in response. And to help us with that, we have the Lusaka agenda. This was chaired by the government of Kenya and the government of Norway, chaired by Jon Arne Røttingen and Mercy Nyeru from Kenya. And it actually started in 2023, before this latest crisis. So there's been thinking, fortunately, around this issue for a long, long time, and the need to reform the global health architecture. And I'll not summarize the recommendations, but the key message I would say is that we need to discuss and reform the way we support countries, not bypassing them, but the direct support. It's all about shifting the power balance to the national level, supporting countries with decision-making, policy and planning. And that leads to my 3rd point, priority setting, values, and the ethics of priority setting. Because we have always had scarce resources, we have always had budget constraints, and we need to have this discussion. What should country do? What should they invest in? What kind of services to provide? Which groups of patients to protect? And my ethics is quite simple. I think priority setting should aim to maximize health impact, financial risk protection, with extra priority to the worst off. Not everyone agrees with that, but we need that discussion because we always need to make and set priorities, choosing within constraints and now even more extreme budget constraints. So I'd like to welcome the panel. Maybe you can start coming up on the scene, starting with Dr. Addis Tamira, who is Senior Director of Integrated Health System Strengthening at AMREF Africa, Ethiopia, and now Acting Director for AMREF Ethiopia. And he's working on implementing primary care services on the ground. Next, Calypso Chalkidou, who is Director of Finance, Performance, Finance and Delivery at WHO. And Jon Arne Røttingen, who is CEO of Wellcome Trust, and one of those who had the initiative for the Lusaka agenda. And to lead us through this discussion, we have Joya Mukherjee, Chief Medical Officer in Partners in Health, and also Associate Professor of Global Health and Social Medicine at Harvard Medical School. So over to you.
Great. Thank you so much, Ole. I'm excited to have this conversation with all of you. I think you all bring very unique perspectives. And I agree that following Dr. Nishtar's excellent summary of where we are, I think when we think about priority setting, the idea that was hatched at the Future of Global Health Initiatives, or the HGHI, that came up with the Lusaka agenda, is a very important thing to revisit. So I'd love for all of you to start with your perspective briefly on what are the external and internal drivers that you see right now in global health. So Addis, why don't we start with you?
Yeah, thank you very much. Thank you very much again for this opportunity to basically speak on this very important point. And I think that we are at a critical inflection point where the core challenge in global health is not basically no longer identifying what works, but deciding what to prioritize when we're not able to fund like everything. That basically takes me to the point that who should be like setting priorities and actually we believe that formally governments or countries set priorities, but in practice priorities are co-produced and often fragmented by lots of internal and external forces. So externally, vertical programming, donor earmarking, global health security agendas basically drive the decision making, and internally priorities are basically driven by fiscal space, the political economy realities, and institutional capacities. So in many settings across the continent in Africa where I come from, priority setting is less about making the optimal choices, but rather about navigating constraints imposed from inside and outside the system. So that's exactly, we were talking about the Lusaka agenda earlier, and that's exactly where the Lusaka agenda comes in, calling for a shift to a country-led, integrated, evidence-driven prioritization by countries, while partners basically rallying behind national-led systems.
Thank you. Calypso, I'd love to hear your take from a WHO perspective and what you're seeing in countries where you support.
Yeah, I think it very much depends on the money, really. Mm-hmm. He who pays the piper calls the tune. And I think, so let me give you some numbers, right? Let's talk about the poorest countries that Ule mentioned, were referenced in terms of the macrofiscal squeeze there, Andrew. So in the past 15 years, out-of-pocket spending grew faster than domestic public spending on health. The past 15 years. So out-of-pocket households, the poorest people, spending to access care when they can afford it. Many can't. This is the most inefficient and most inequitable way to finance a healthcare system. That was the fastest growing element of spending on health across low-income countries. Domestic public spending grew during 2020, during the pandemic, and then declined. So now we're back to where we were in 2010. So this is 15 years of basically no growth at all. And the health priority that governments put, the poorest governments place on health as a proportion of their domestic budget, is hovering around 6%. And the Abuja target that countries came together and agreed to is around 15%. And in fact, domestic spending on health lags behind both out-of-pocket spending and development assistance in the poorest countries, in the low-income countries. So priorities in these countries are very much set by the parliaments and by budget cycles and by advocates and effectively by mechanisms of allocating budgets in wealthier countries still. And that's why I think the Lusaka agenda was quite topical, because it tackled this particular question. And now the question is, of course, what happens next?
What happens next? Yanarne, you were the co-chair of the process that produced Lusaka. So maybe you can, summarize, given what Adis and Calypso have said, how is the Lusaka agenda moving us forward, as Dr. Ivers commanded us?
Good idea, good set of directions, no willingness to implement. I think that's the...
I hate when that happens.
That's very common in the academic community, and it's great to be back here at Harvard, and actually the collaboration between the two sort of affiliations I had when I was here as visiting and then later adjunct professor. Maybe briefly, the driver of the Lusaka agenda came both from in particular the African continent, feeling left behind and really doubling down on language around health sovereignty, aid independence, having their own means in manufacturing and maybe with the wrong focus, because vaccine is the hardest by whole sort of commodity to produce in many ways. So that was a strong voice. And then the other process where I came more from, because I was then Global Health Ambassador of Norway, I had led the coordination of resource mobilization for the pandemic across vaccines, therapeutics, and diagnostics, and PPE, the ACT Accelerator. And where the donor governments were really pleased with the fact that finally we had a common platform to actually discuss allocation of resources across the different institutions, the global health initiatives, but also the WHO, even though we didn't influence the World Bank, but at least there was a clear communication with the World Bank. So there was sort of a drive from both donors and what we can, still that dichotomy, the recipient countries, to have a common process and conversation. And the direction was very clear, and we heard it from Ole as well. It is about countries deciding priorities. The challenge is that there are two systems of accountability. It's the political accountability in the recipient countries, and then it's the political accountability in the donor countries. And where the resource mobilization, and I think US is the most sort of clear-cut example of that, it goes to very specific health outcomes or technologies or diseases. That's the easiest way to mobilize resources. And how do we square that dilemma? And just I led a global health financing working group at Chatham House now probably more than 10 years ago. A real basic basket of healthcare for everyone is maybe costed around $100 a year, and that's still a basic basket. If all countries spend at least 15% of general government expenditures or 5% of GDP, and it depends on their tax income opportunity, there is still a lot of countries that would not be able to meet $100 per capita per year. And the challenge is that if you cost that up, it's more than $100 billion. It's way above what we ever do. And then, so the money is a problem, and who are accountable for that problem? And then you would say, should we then take a zero budgeting approach, which we in a way have done for AIDS, TB, malaria, and decide we will fully cost these interventions, and we will have programs to deliver them to eligible countries. We will do the same for vaccines, fully cost them, and then have some copay and all of that. Or should we leave that sort of prioritization dilemma to recipient countries? I think we haven't decided on how we will do that. I am very much leaning towards we need to actually give that responsibility to countries. Because health is a political fight. It's a struggle.
Sure.
You need to have, the politicians need to be accountable. You need to have those discussions in countries. You need to mobilize taxation and reduce illicit financial flows. And that the politics is local. Politics is domestic. There's no global political system in that sense, and even less so than ever.
And I think you bring up such an important point, which is this notion of sustainability. What is actually sustainable on the scarce resources of countries? And if, is it okay to say country X has $20 and that's the best they can do, and country Y has 120? And I think we will continue with the inequities if we do that. And I think when Ole mentioned the idea of financial protection for the most vulnerable, that is going to mean, for equity's sake, to resource the poorer countries and the poorest communities more. Adis, maybe over to you.
Can I just
comment
yes,
briefly? Of course, yes,
Sonia
please.
didn't want to define global health. So I actually I Googled and I looked what is the definition of global health. And one definition is global health equity.
Yes, yeah.
Which is a very expansive definition. Yeah. Then last night I was in a dinner in DC, including with the former health ambassador, or global health security ambassador of the United States, John Nkengasong, and he said, there is no such thing as global health. If we want to talk about global health, we could potentially talk about global health security, which is a common challenge, and then risk norms and standards. But otherwise, health is local, national, and we need to accept that. Those two perspectives are really different.
Really different. Yeah.
And I think the global health equity part is not high on the political agenda in almost any country currently. I think that's the reality of the world, really. There's really low level of solidarity. We should fight that, but that's still the political reality.
Yeah. And I'm a moderator, so I will refrain from putting in my opinion. So over to you, Adis. The Lusaka agenda calls for this increased domestic resource mobilization. You're at AMREF, but you've also worked at, in the Ethiopian Ministry of Health as Chief of Staff. How do you see that domestic resource mobilization at a country level, given all of the competing challenges of what's happening in Ethiopia and elsewhere? Who will pay for the health? Because as Calypso reminds us, it's not that nobody's going to pay for it. If the government doesn't pay for it, if donors don't pay for it, it comes out of pocket. So what is your perspective on that as a real possibility?
Yeah, so I think it's important that we're basically addressing two important things. One, answering the question who pays is incomplete without properly addressing what do we mean by sustainable. So I don't think that everybody is on the same page when it comes to sustainability. Some believe that sustainability may be interpreted as full domestic, financing in the short term, which is not actually, realistic for many African, countries. So sustainability should also include the ability of countries to basically prioritize, allocate, and use resources for their own, national priorities and interests. And in fact, there has to be accountability attached to that. So to be able to do that, countries may probably need to have three important things, I would say. One is the prioritization. That's being explicit about what's basically funded, and the efficiency and integration is also critically important. Moving away from fragmented vertical programs towards systems that can deliver multiple outcomes with the same amounts of resources. And third is the redefined partnership model where the external financing is properly utilized. Dr. Nishtar was saying that external financing is not going to disappear 100%. It's going to be around, but making sure that is playing a more catalytic role and is more aligned and is more supportive of the national priorities rather than further fragmenting them is very important. So for me, sustainability is less about who pays in absolute terms, but more about how intelligently we prioritize, align, and use the resources we already have. So in that sense, sustainability is not a financing endpoint, but it's a discipline of decision making under constraints.
Yeah, that's a really interesting perspective, the idea of discipline and where the priorities are. And that really leads me to ask you, Calypso, in your role at WHO and looking at things like performance-based financing and how you improve delivery. The Lusaka agenda puts the WHO in a bit of a driver's seat there in terms of harmonizing frameworks and tools. How do we support that at a country level?
Yeah, thank you. I mean, if I may again cite some figures.
Please.
I think it'd be good to zoom out a little bit. So, I think countries need to spend more, and as you said, it's very much about how the money is spent. There's a lot of efficiencies and to be had and better distribution of the resources, however little money there is. At the same time, however, especially the poorest countries are operating within a structurally unfair system.
Yes.
So there's some embedded inequalities in the global financing architecture, which make it very difficult for very poor countries to grow themselves out of poverty and find that additional money that is needed to invest in their own population. So, for example, in 2023, Africa received $74 billion in aid across all sectors, and it lost twice as much to illicit financial flows and corporate tax exemptions. And it takes two to tango, so the money went somewhere towards the north.
We know it has gone.
Right. So that's one thing. Africa, on average, spends twice as much as a fraction of their gross domestic product, on average, on servicing its debt than it does on health and education together. So, and these things are getting worse because the IMF is deeming countries not to be poor enough to default, so they should continue servicing their debt. And that debt eats into the fiscal space countries are able to allocate towards health. So I think we need to remind ourselves when we talk about domestic financing, we need to talk about international taxation and tax rules, and we need to talk about debt. Otherwise, it becomes a little bit problematic, just focusing on specific interventions and technology. On what WHO is doing, well, I mean, we've had a lot of requests from countries during this health financing emergency, really, because I think it is really an emergency with support requests on how to prioritize. And I think that's quite important because priorities are being set by default because of the financing decisions made, whether at national capitals in recipient countries or here or in DC or London or Geneva. The question is, are there explicit priorities? Can the trade-offs be quantified and elevated? So who's losing, who's winning from those decisions or not? And usually they're implicit priority setting process, and that's why it's important to make this explicit. So our work is very much on the process side, and we very much look forward to working with Ule and his colleagues here at Harvard as well, looking at priority setting processes and the analytics that come. So as these decisions, these choices governments make, what to allocate, what are the opportunity costs and who bears these opportunity costs, developing tools to help countries make these decisions on costs, and also trying to plug these priority setting processes into budgeting processes so that once a government prioritizes something, then there is a process through which the money actually follows through. Budget cycles, midterm expenditure frameworks, so bringing the two together, ministries of health and ministries of finance. So I think that's a big gap and it's quite important.
Great. Thank you so much. Jan Arne, I'm still gutted by this idea that there's no global health. So I'm gonna ask you to go into, since you were there framing the Lusaka agenda, the idea of national sovereignty and what does that mean. I want to understand a little bit more. I'm going to go off script. Sort of how the ideas of debt and tax flows and all of the resources going out of Africa to the West, how did that play into these discussions around sustainable health financing? Because even if governments do more, they are so constrained. So what is your sense of that?
So I should be honest and say that that did not play a big role in the Lusaka agenda process, partly because it was really driven by health people in a way, both from in particular Africa and also from those involved from donor countries. I think a big challenge, and actually in my country we tend to say you can meet yourself in the door in a way. You have some principles, and then when you try to apply them, suddenly you get them up in the face really directly. And so I'm definitely in proponent for sort of countries need to decide, make decisions, prioritize, do the explicit trade-offs, and consider. So in a way, that means de-earmarking some of the clear ambitions from donors and willingness to come together. There are potentially some exceptions, and I think the worst of sort of exemption, the key population marginalized groups, there are human rights sort of arguments that we could, with sort of solid foundation, use. But then, sort of, if you follow that, so what? And I'll get to your question, because why should we then even earmark to health? Why? Because in a way, and that's where I am struggling, because I'm a physician. I care about health. I see that countries under prioritize health, but that's really the key, because in a way, then we only, in a way, at least talking about the balance between domestic and international, in a way you should allow it for countries to decide, and so there should be a general development finance instrument, and they should allocate resources to sectors, and in a way they have been doing that, because there's solid evidence on crowding out domestic finance because of the very strong impact the global health grant financing has had on the opportunity to finance health, and then governments decide to reduce their own domestic finance. That's a decision in Ministries of Finance, and they finance other sectors. But the challenge, so in a way, then we go back to the era before even we had dedicated big grant funding mechanisms, or before the year 2000, as Sonia alluded to. And of course, these were created because we were not happy with let's say, the World Bank and the development banks as the only finance instrument. And that is then linked to the debt. So should we only solve this on the sort of financial flows and the international financial system? No, I don't think we should, because I think we should be drivers for, in particular, making sure that human capital and sort of the human social phase of development is high on the agenda, sufficiently high. And we have history demonstrating that countries do not prioritize this. And in particular, when it comes, and probably their instruments that they negotiate with, the development banks do not prioritize it, because the return on investments are too far away.
Too far, yeah.
And so we see it now. Actually, the portfolio on health projects in the MDBs, including the World Bank, is going down instead of going up. And they invest in energy, in critical minerals, in transport infrastructure, in digital infrastructures, and if health, it's tertiary hospitals. So I am then, okay, I am for...
You're meeting yourself at the door.
Exactly. I am for earmarking to some extent, or incentives at least, on making sure that countries are incentivized to use some of the external finance for the health sector. But that needs to link to...
But I think there's two fallacies, if I may, what you're saying. So the first thing is you're confounding health with TB, HIV, malaria, and vaccines.
No,
well, about
I'm not.
3/4 and more of the grant money that went to health through these global health initiatives actually went to these things.
Yeah, but that's the...
It went to these things during a time of emergency, and it should have gone. But then it continued flowing to these things during a time was not an emergency. And so we've lost the idea of systems, because it was hard to grasp, I guess. And WHO is also responsible. What is a health system, and does it return?
My point is that earmarking to health is not necessarily earmarking to single diseases.
It's not, but we made it be that over the past 20 years, because we've channeled health aid money through vertical channels. And as you say, there's quite good evidence that this crowded out government investment, not just in these specific disease-specific and technology-specific and population-specific areas, but crowded out money towards health.
Yeah. And it increased the willingness to invest in health in donor governments. I think that's the big challenge. We don't have a defined envelope of money we can maximize the use of. That envelope is dependent on how we structure the system. So it's an interdependency here that is so hard to reconcile. And in the US, that's decided in Congress, really. Bipartisan leaders coming together, let's now go.
With a lot of support from civil society.
Of course.
I mean, we're going to talk more
but
about.
the second problem is that grants also have an opportunity. So IDA, for instance, can range from fully grant, long maturities, very low interest rates, effectively it's a grant, all the way to concessional towards high street rates when we head towards IBRD. Grants channeled by the government of Norway through the Global Fund. Okay, Norway is a wealthy country, have a surplus. Let's take another country, let's say Greece. Very little money, yet contribution. This is usually borrowed money, right? So there's an opportunity cost there. So I think we need to move beyond this sort of dichotomy between this is purely grant and this is purely loans, and grants are good and loans are bad. Yeah. So I think going back to the macro fiscal and looking at what treasuries are doing is quite important. Ultimately, we need to accept that countries will have to make some decisions. All we can do is put the evidence out there and push for a pro-poor, pro-health policy. And then if we're going to walk the talk, then we need to step back and stop distorting the global.
Before I go back to you, Jan Arne, I'm going to bring in Addis for a second, because I think what Calypso is saying about these vertical financing being sort of driving the agenda, maybe we've all seen that to be true. However, I would say in my own experience, working in many countries in Africa, many governments smartly used those vertical monies to develop very robust systems of primary care, and especially in that first, let's say, 10 years of GHIs, a lot of the money wasn't for commodities because we didn't yet have those people on therapy, and that money went into. Can you?
Yeah, I think Ethiopia.
Confirm or deny for Ethiopia?
Yeah, I can do that to some extent. I think Ethiopia is a very good example of that.
Yeah.
Whether it's the Global Fund for HCV malaria, Gavi for the vaccines, and so on. The other instruments, Ethiopia has been receiving this vertical funds, but it has smartly basically used those resources to build its systems.
Yes.
Like look at the data systems, the supply chain systems, HR and everything. And I think through time, this different mechanisms have learned that having a window attached to it, HSS window, would be helpful. And I think they have come up with this idea of having a window attached to this different funding mechanism. So definitely, it's ideally you would want to have unrestricted or unearmarked funding, so that you are able to have your own priorities defined and able to support your own priorities with those kinds of funds. But if that's not the case, you should not be wasting your time, pulling all those arguments that it has to be this way, it has to be that way. At the country level, once you are very clear about your priorities, what you need to do with the resources, then you can stretch every dollar actually to basically make sure that the requirements are met on one side, and then you are able to build your systems on the other side. So I think multiple countries in Africa, including Ethiopia, Rwanda, and Zambia, Malawi are very good examples, I think. Yeah.
Thank you. Jan Arne, you wanted to jump in here.
Yeah, I should probably be honest to talk a bit about the opposition against the Lusaka agenda as well, because you mentioned civil society. So the main opposition, the clear opposition, was from the chief executives of Gavi and the Global Fund, just to be very open. And they wrote letters to me, and they were not nice letters.
And why? Tell us a little bit more about why they would be
of course, because they were afraid of this would undermine their ability to mobilize resources and actually be dedicated and on their mandate and get sufficient funding for agendas that are really important and also still not fully funded. So I'm not criticizing their motivations. Yeah. It's a good intention.
They were sort of in favor of staying more with the vertical for resource mobilization.
Yeah. And then playing lip service that say that, but we do coordinate and are coherent at country level, and we have country coordinating mechanisms. We follow national plans. And then you check with the government of Malawi. I was in Malawi 3 weeks ago. They needed to have more than 50 different national plans, because the plans needed to adhere to the needs of the different donors. In Ethiopia, what I heard from Ethiopia recently is that they have more than 200 contracts or agreements with external funders. yes, that is, you can maximize, with good leadership, you can maximize the use of that, but it creates a big
huge burden.
It's a headache.
Burden,
It's a
yeah.
headache.
But I should say that the strongest opposition against the Lusaka agenda discussions were really from civil society.
Okay,
And
why do you
advocates.
think that is?
No, because we have organized, in particular in the global north, organized civil society to be advocates for the diseases and the technologies we think are important. And this is probably even most on the global fund agenda. And in a way that's great, because that was also the AIDS movement in particular was the driving force for establishing these instruments. And it was the driving force for expanding the financial envelope for health aid, which is great. But then, as I said, when you then take disease by disease, zero budgeting, any attempt to reduce that, any attempt to reduce the number of countries eligible for global fund support to concentrate in the poorest countries where there are really big needs, will have opposition from that civil society advocacy.
Yeah.
And the US is full of these organizations, and they have been funded well by philanthropy. And they go into DC and lobby Congress, and there is a machinery sort of that is built to just make this system sustained. I don't think that is wise, but so I said to another big foundation, that you have created this problem, you need to fix it, because they fund it.
Interesting, very interesting. I'm going to pivot a little bit to talk about something that was also mentioned in our keynote about sovereignty in terms of R&D. And how do we get the tools? When we look across the big gaps now with the US changing their tune, a lot of it is around commodities, around drugs, diagnostics. So now you are the head of Wellcome Trust, and the Lusaka agenda does call for coordinated approaches to R&D, manufacturing, market shaping. You know, how do you see that as a way forward toward sovereignty?
Yeah, and again, a moment where I meet myself in the door, because and here it's in principle, there are some principles here that actually do collide, because the research and development agenda, in particular when it comes to technologies and so new medicines, new vaccines and so forth, it's a global enterprise, it's a global ecosystem. So when we have, let's say, and we have three challenge areas that we have prioritized: infectious diseases, mental health, and climate and health. And in particular, in infectious disease and mental health, we are focusing on supporting science to develop new solutions. And then we set, in a way, we look at the global ecosystem, we look at the needs, we look at the portfolios, and we see what other funders are doing, and then we prioritize where can we make a difference. So we schistosomiasis, leishmaniasis, arbovirus, vector-borne viral diseases, antimicrobial resistance, just to mention some within the infectious disease space. And the problem then, and that is rational, because it's rational from a global point of view. But then we fund centers. The reason I was in Malawi, we support a large research center in Blantyre, similar in Kilifi, similar in KwaZulu-Natal in South Africa. And they, of course, they see the local infectious disease challenges. They want to do applied research that are really addressing the needs of their communities. And how do we negotiate that in a way? And that's where it's a trade-off and it's a dilemma. So what we try to do is, in a way, we need to have open schemes and calls where they can define the needs based on discussions with their local governments and then come with applications, and we build that into our core support. But there's still a need for also that global perspective. But definitely the Lusaka agenda is more about also equitable partnerships in research. We have made a decision to gradually increase our portfolio funding directly research in low and middle income countries and not through academic institutions in the global north, and so that, but the researchers in low and middle income countries can partner, but they need to define and identify their partners and be the core sort of leaders on programs. But this will take time. It's a gradual transition.
Adis, you want to jump in here?
Yeah, I just want to talk a little bit about the sovereignty thing, because it seems to be the mood in the air at the moment. So at the continental level, the African Union has launched the Health, Security and Sovereignty Agenda, which basically signals a huge drive towards self-reliance. So it's an important thing to have. But my concern is, sovereignty has to be matched with commitment. It has to be matched with accountability. Because in 2001, we had the Abuja Declaration, and it's been how many years now? 20-something years. Only 3 countries in Africa have basically achieved or exceeded this commitment. More than 30 countries are still allocating less than 10% of their national budgets to health, and some are basically doing something between 5 and 7. So I mean, we can have commitments, we can have declarations after declarations, we can have lots of things, but unless those things are matched with accountability and real commitment on the ground, it doesn't really help. And also, we're talking about local manufacturing. It's important. Africa needs to have its own local manufacturing capacity, whether it's medicines, vaccines, diagnostics, whatever, essential medicines or so. Where are we now? We've been talking about local manufacturing for the last several decades. Where are we now? We're importing more than 90% of the medicines, the diagnostics, vaccines from overseas. So we need to have, we need to move forward with some concrete steps. I think we've had enough commitments, declarations, and so on. Now it's time for action.
Yeah, that's great. Calypso, what is your perspective on the sovereignty issue? How are you seeing that play out from your interactions with countries at WHO?
I think it's a very real movement, and it's great to see senior leadership across Africa sort of state these things. I mean, as they said, we've had these declarations for a while, but now seeing, again, at the presidential level, even it's not just ministries of health, and it is presidents of nations coming forward and saying, we want to drive our own priorities, and we will invest and all of that. So I think that's important. I think this is the time where we need to start seeing action, as you said, and in my mind, action is budget allocations, one of the proxies, right? So looking to see whether governments are indeed increasing allocations to health, whether they're taking measures to improve efficiencies. If they want to exert industrial policy because they want to produce locally, are they doing that? What's happening to AMA and other mechanisms, the free trade area across Africa? So what are the movements that countries are making towards improving trade conditions, tapping into their own sovereign wealth funds to invest in health, education, human capital? And these are things that can be measured, right? It's not like they're not apocryphal. We can see whether they're doing them or not. So this is the time that we should be seeing those shifts happen, and the jury, I think, is still out. But I think having the statements to start with is important, and it's been a bit of a wake-up call, right? I mean, the latest shock in terms of the cuts, the sudden drops in aid, people realizing that they're not in control of this money, even less than perhaps they thought they were. And so I think that's not, well, let's see.
Yeah, let's see.
Yep.
Yeah, go ahead.
Yeah, I just wanted to make one balancing sort of statement to what I said before. I mean, there has to be that commitment, matching of accountability and everything. I keep on reiterating that, but what fiscal space are they basically playing with? Yeah. So in Ethiopia and across much of Africa, the fiscal space is quite tight, very, very tight, because of rising debt, the debt pressures, competing priorities, and lots of other things, including like the illicit financial outflows. Debt, if you, for example, take the debt in 2025. The Africa debt service amount was $81 billion, actually way higher than what it basically received that year from external sources. And then if you take the illicit financial outflows, it's very significant. For example, in my own country, Ethiopia, where in 2023, it was like 1.5 to $2 billion, through base erosion and profit shifting. So there is a bigger problem around the size of the pie.
Yeah.
The size of the pie is still very, and it's very, very crowded. So we're basically asking more from that already, very, shrunken pie. So countries need to take some real actions in terms of how they could expand, this pie through, improving their, tax administration and policy measures, and also negotiating on the debt front, something that the global community has to do, something about. The illicit financial outflows, which is basically eroding, the continent in lots of ways. So I just want to make that balancing, certain.
No, so it's so important, and I think even the illicit financial flows are even being normalized and legalized in some of these bilateral compacts that the United States wants to sign with different African governments, trading mineral rights for ODA. So they're just making that more plain, but it will still have a profound impact on countries. And I know there's some countries like Zambia that are saying, we're not so fast with that, trading our sovereignty and our mineral wealth. But
this is not new, because
no,
in a way,
it's naked.
It's been for decades. And again, this is also a responsibility, of course, for national decision makers, because natural resources, oil, gas, gold, critical minerals, the economy around that has been heavily concentrated in many countries in Africa as well. So, and there are local nationals, politicians, that have benefited extremely. Corruption, and but also the way the tax system and the way it's structured. So the illicit flows are not only bad actors coming from the outside, it's actually really bad actors from the inside, and the lack of accountability to that. So it's of course, it's a democratic challenge. It's an accountability challenge. I would just want briefly to also, given we were on the research agenda, I see what we have not done sufficiently in the past is to try to engage with local governments to establish research investments. Because in a way, it's easy to say, okay, governments first need to invest in healthcare, and until they have reached a certain level of development, they shouldn't invest in research. But I think that's flawed. I think it needs to be done in parallel.
Simultaneously.
Exactly. And we have not had good sort of dialogues with governments necessarily. We have funded from afar, really, and individual institutions. We are now in Southeast Asia establishing a collaboration with the ASEAN countries, and we are looking into more co-financing opportunities. With the government of India, we have a great collaboration. They now fund 2/3 of the cost of the program. We fund 1/3. So building up that capability alongside, of course, domestic financing. And this is linked to the manufacturing agenda.
Yes.
So it is, the manufacturing agenda is high, and I understand why. It creates jobs, it creates like economic systems, so health is then not only an expenditure, but it's actually a part of the economy.
Resource.
But in a way, as I mentioned briefly, it's unfortunate that it became the vaccines and that became the poster child for this, because it's the hardest commodity to produce. Yeah. I closed the last sort of commercial vaccine manufacturing facility in Norway. So there's no vaccine manufacturing in Norway, among the richest countries in the world. If you look at the European countries, there is only a minority of European countries that produce vaccines. And still, presidents in Africa, they all want their own vaccine manufacturing facility. That's irrational.
That's irrational.
It will be a lot of sunk costs and sort of investments that are not used. So how can that agenda be driven towards, other commodities?
And you think the less complicated would be like essential drugs or something? I mean, you're not saying no manufacturing, you're saying not the,
Yeah, and like many other countries, you import API and produce locally, and then gradually start producing API, active pharmaceutical ingredients, and do fill and finish on vaccines, gradually maybe start with some antigens and concentrate it in just a few countries. I think that's the only long-term viable. We hope now, we fund the large TB vaccine trial together with the Gates Foundation, more than 20,000 enrolled. We hope the results will be ready and positive in 2 years from now. That is a good example of a vaccine that should, at least part of that production should be done in Africa and in Southeast Asia with the biggest burdens of TB. So how can we use those new instead of all countries wanting them mRNA facility, and then the only mRNA vaccine that is approved is COVID, and the need of COVID vaccines is plummeted. So.
That's where there's potential through the vertical funds, for instance, to shape the market and buy local, right? So you have demand that's at least for a few years guaranteed. So that's an incentive for DFIs to come in and invest and companies to step in and so I think that's an opportunity there. But I wanted to just on the question of solidarity, I think it's quite important to remind ourselves that solidarity is about risk pooling. And it's not just when I was talking about the sort of broader economic system, it's not charity, it's corrective action. When governments after the Second World War got together and set up the IMF, Bretton Woods, they were looking at that solidarity because it was beneficial to all. They agreed that that we all need to grow, all economies, and we've lost that. And it's now become about, it's become extremely fragmented in so many different ways. We now talk about regionalization, but you don't want regionalization when it comes to financing. You don't want Africa to be on its own, and you want Europe to be on its own, North America. You want these broader risk pools because that interdependence actually is a good thing. And you want, in a sense, markets. You want people to become wealthier to be able to consume. And that's not like a Marxian argument. This is pretty a market-oriented argument. We need to remind ourselves that that's what we should be talking about. And yet what we're seeing now is that MDBs which step in to support countries in distress or near distress end up underwriting and servicing private lending. And so Africa has become the biggest creditor to the world. So that's the sort of the exorbitant privilege, right? There's a strong empirical evidence that shows that a large amount of money leaves Africa and goes elsewhere. And yes, of course, when it comes to governance and all of these things are important, but I think it's important to talk about, even from a self-interest perspective, about risk pooling, about sharing responsibilities. And to a very, very last point I want to make on health. And I think it's also important for organizations like the World Health Organization, people who work in health, to talk about the economic and social returns of investing in health. And again, we sort of lost that a little bit. And it's important. Language does matter. We need to remind ourselves. And these are resolutions and commitments that were voted in the 70s. It was very clear. The PHC resolution, Almata, openly talked about social development, about economic development, and how it's important for people to be healthy.
And our shared responsibility.
Our shared responsibility, globally. Exactly. And I think we need to return to that language, remind ourselves a little bit why, I mean, after all, you know, it does matter.
Yeah, great. Adis, would you like to talk
just
about sort of solidarity?
Solidarity, yeah. So I think probably from now on, we have to, solidarity somehow has to move from rhetoric to choices. And for me, solidarity should be anchored on three important things. One, alignment. Second, equity, and third, efficiency. On the alignment, you know, we've talked about it. It's like supporting the country's priorities, making sure that, you know, whatever we do is not disrupting systems or creating any parallel systems. And on the equity front, protecting the most vulnerable, as Professor Ola, you know, put it at the beginning, protecting the most vulnerable and prioritizing the high impact, you know, services, especially at the primary healthcare level, particularly in Africa. And third, the efficiency, ensuring that, you know, we're delivering the maximum value for every dollar that we're investing in our health system. So I think when budgets are sort of shrinking, solidarity is not about adding more. Is more about how we allocate what basically remains in our hands.
Yeah.
So Sonia mentioned this briefly, but I think an important tool, and I think it's a good opportunity to do it now. It's really to take a relook at the OECD DAC rules on what counts as official development aid. And there are different views on this, but I'm of the strong held view that we should differentiate, as Sonia also said, solidarity in a way, so support to individual countries where we want to support from an enlightened altruism or self-interest in some way, and the public goods, and given that the 0.7 target is now so off, it's sort of no country except my own country, Ole's country, we are still at 1%.
Go Norway!
But we are benefiting from the wars in the world. So just to take down that self-image, we should actually differentiate. So take out the first-year migration cost completely out of the picture, have a solidarity component and a clear global public good component, and then do advocacy for. Still, the world needs solidarity, but then we need efficiency as well. And the global health aid system has been expensive. And I think so. Minister Pate from Nigeria has said on the stage, and therefore I can say it many times, that they believe they can deliver the HIV program at 40% of the cost of the former program that was very sort of bypassing programs and funded externally. The challenge is the transitioning, because pay scales are 2, 3, 4 times higher in those programs, and the same is in South Africa. So when the government needs to take on this, you have a big movement of people who have been used to have salary levels that are higher than in the normal healthcare system. And how do you reconcile that? That's hard. It's hard for those individuals, of course, but it's also hard for the system. So we need to be much more accountable when it comes to how we do align with country systems and levels and support in a truly solidaric way.
And just to say, as the only American on the panel, I mean, a lot of the way U.S. has given aid has bypassed governments, has gone to NGOs, has gone to sort of these trainings and per diem economies that really did not, help people. So,
but it's not only the U.S. It's our collective instrument through the Global Fund is another definitely doing the same, and a lot of European bilateral aid is doing this as well. And it's a big aid industry where people fly as consultants in and out, and as some. And the pay levels in Geneva are also quite high.
Calypso, he's talking to you.
And they don't pay tax even, so how should we?
Whereas the Welcome Trust legacy is fair. Let's look at the history of the Welcome Trust. Exactly. And now the next step we're going to fight here on.
Well, I am just delighted that we had such a spirited discussion, right? I mean, I think these are very unique perspectives, and I think as we think about our way forward, bringing people to the table with very different opinions, some similar opinions, different experiences is so important, and to really hash these things out together. I'm grateful for all your honesty and integrity, bringing your true voice and true opinions to this discussion. So thank you all so much. We may have time for 1 or 2 questions.
Thank you.
Yeah, Ali Yeaman.
So thank you very much for a really provocative and thoughtful discussion. It strikes me that there's, you've all in many ways identified the same fundamental issue, which is that you can't have health sovereignty without political sovereignty, which you can't have without economic sovereignty. And all of the structural conditions that limit that for many, many countries across the world. And yet when it comes to solutions, the global health community falls back on pragmatic tweaking here and there, and there's no wonder that this global health community is constantly criticized for sort of taking managerialist approaches to egregious inequalities and injustice. So is there a way to move beyond that with much more dramatic and bold interventions that we could, and we have a lot of people in the room representing governments, important institutions. Thank you.
Anybody? Yeah, go ahead.
I think the Financing for Development conference, for instance, and the consensus reached in Seville is an interesting first step where it positions financing for SDGs, specifically for health in the broader context. And there's some recommendations, some actions we're seeing, though not deeply radical, but, for instance, looking at how to use special drawing rights in a different way, looking at how to boost local currency markets in countries, and regional development banks do lend in local currencies because that's a big issue. Or looking at debt, addressing the debt and debt servicing and the cost of debt, risk perceptions, credit rating agencies. So I think that's all important. It doesn't mean we shouldn't keep the focus on health, but the health community is quite well, impotent to some extent because we're not that plugged into that other conversation. And I think conferences such as this or movements such as this are more helpful than ourselves talking to ourselves. And that's why I think the Accra Reset and the latest drive from African presidents, the fact that you have the president of a nation or multiple nations actually using health as a spearhead and saying, well, actually, we do care about health at this point in time, and we do care about these economic and structural injustices, and we want to change the equation, including on illicit financial flows and trade, terms of trade, etc. But using health in their language and their narrative as the entry point, that's encouraging. But now we need to see what comes of it, and we don't have, a lot of time, and it could be that not much comes of it, it could be that things do change. But I think bringing those communities together and framing the domestic health financing conversation in the broader macroeconomic context, I think is an important starting point.
Okay, I don't think we have any time for more questions, but I want to thank you all so much.
Thank you. Thank you.
That was great. Thank you.
Yeah.
Thank you.
Thank you to our panelists. They really reminded us that we not only need, but we must talk about money as we move forward. Now we have about 20 minutes for coffee and conversation. We'll resume promptly at 11:25. Thank you.
WHO Afro. Yeah. Okay. So are you?
Marna is a physician, oncologist at Mass General, and does a lot of work on access to global oncology treatment and training of oncologists in Africa and India and lots. That's the high-level summary.
Yes, the WHO, we're there.
Mike's is live.
Oh!
I think it's yours.
I'm live. Luckily, I'm...
is it? 5. Is it? Oh, thank you, thank you. Hello, everyone. It's time to get back into the room. Please find your seats. We're going to start shortly. If I could have the staff help get the people inside, it will be amazing. Some extra help needed. The coffee time. Yeah. Seems like everybody's having a wonderful time catching up, talking about many important things today. So thank you for your time. We're going to get started. Welcome back, everyone. We're moving now into a conversation that sits at the very heart of our mission here at HGHI, from risk to resilience. We're looking specifically at the emergency preparedness across the African continent. It is my pleasure to welcome Dr. Dick Chambla, the emergency preparedness lead at the WHO Africa Regional Office. He is joined by our faculty director, Dr. Luis Ivers, who will lead the conversation. So please enjoy. Thank you.
Thanks. Thanks, everyone, for joining us back after the coffee break. And thank you, Dr. Chambla. It's a pleasure. I'm going to start with a few questions from me, but then we will open it up to your questions. So please get those ready as we go through. So you have worked across national ministries of health, WHO Afro, you've done frontline outbreak response, and now you're working on regional preparedness systems. Can you tell us a little bit about the through line that connects those experiences for you, and whether there's been a specific moment in the field that fundamentally shaped how you think about emergency preparedness?
Okay. I really appreciate an opportunity to be here again at Harvard. I think, and also I really appreciate an opportunity to really talk about preparedness. Globally, it's only few people who are talking preparedness. Oftentimes, at the time we're talking of emergencies, we're only talking about response. So I'm so grateful I'm here, I'm talking about that. And hearing from a previous panel, I need to remind all of you, in Africa, we have every year 100 to 120 emergencies every year. And these emergencies are ranging from outbreaks, from climate-related disasters, and also from armed conflicts, aka humanitarian crisis. As a result, at the time you're all talking about priorities in health, at the time you have emergencies, all priorities change. Because entire healthcare has to respond to these emergencies. As a result, I didn't hear it a lot in the panel. It's okay to have emergency, many priorities in terms of peace. At the time it comes to emergencies, all priorities will always change. Specific on your issue, it's true I've worked in a lot of countries, actually in the past over 20 years now. Therefore I'm old already from a definition. And that in frontline, I've been really working in Africa, in the Middle East, in Afghanistan, and even in Papua New Guinea. And what I've seen and I've learned in all the countries, it helped me to create the information and the evidence in which it helps to inform the policies and the national strategies. At the time, I was actually at the national level. And at the time I had an opportunity to work at the global level and the regional level, it helped me to see how all those lessons I have from the ground, it was help actually to influence global policies, global strategies, and other things. As a result, what I've really learned in all years in emergencies, we are always reactive. We are not oftentimes proactive. We wait all the way until at the time we have an outbreak or an emergency is the time we are actually starting to act. So what I decided and started to ask, how about if we have appropriate tools and resources in which it will enable us to predict a future in order to prepare and protect the lives of the people and economies. As a result is the reason I decided to shift from a response to preparedness, because I believe preparedness had the long-term impact and the response has only an immediate impact.
Mm. And building on that, I've heard you say before recently in Nairobi at a meeting you were co-hosting as WHO Afro that preparedness is becoming a continuous discipline rather than an episodic activity. And that philosophical shift that you've also mentioned in your opening comment, could you speak to us a bit about what needs to change institutionally at a practical level and culturally for governments and WHO country offices to operate in that kind of way, and what opportunity there may be in this moment of global health to create or to accelerate that kind of shift?
Okay, excellent. I really believe preparedness intersects between emergencies and the development. Okay, and even at the moment, how emergency preparedness are measured by the average score of core capacities of international health regulations, bracket IHR. And if you really look, actually IHR core capacities in which are reflected in Annex 1 of IHR, actually you realize a lot of core capacities are actually the building blocks of health systems. As a result, you wouldn't have a strong preparedness if you do not have a stronger health system. And in order to strengthen preparedness, it implies you really have to have a long-term investment, okay? And the problem is our countries, our government, and even in the WHO, how we are structured is actually we assume preparedness is one-time intervention. Mm-hmm. And actually it doesn't work like that. It needs a long-term actually investment. How do we change that? Is really we need to relook at our structures, okay? We have structures in which are organized in boxes, as you know. I am preparedness, another one is response, another one is data, et cetera, and we have to see how are we able to integrate or even to explore opportunities of collaboration in order to ensure we have a complete management cycle. As a result, I feel it needs time, we need reforms to do that, and actually to also have the mindset. We also have to actually bring in our donors, because our donors are also interested on the results in which are immediate, instead of the long-term results, etc. So opportunities we have at the moment, for example, 2.5 years, we have high-level political declaration of emergency preparedness and response in which it was adopted by the heads of statement. And in the declaration, it articulated one critical thing. It recognized primary health care as a critical pathway to strengthen emergency preparedness and UHC. As a result, how we are heading in the future now is actually trying to recognize that if we are able to create emergency-ready primary health care, actually it will have a longer-term impact actually on preparedness. And another opportunities, we have now global financial instruments such as pandemic fund, in which critically has already recognized it's critical at the time we are talking about preparedness, we also talk about strengthening the systems. As a reason that is also another opportunity. And actually, last opportunity I will remember at the moment is actually even our own regional office of Africa in WHO. We are now creating a regional strategic plan in which we have already recognized to frame preparedness as a part of health system strengthening. Over.
You know, thinking about the structures that you spoke about and the continuous preparation, it makes perfect sense that primary healthcare and health systems are needed for that. Though it's really not that often that I hear those things in the same conversation or the same, or even the same people. So it's very interesting. And could you speak a bit to how practically you think that might move? You know, will pandemic fund be available for primary healthcare strengthening? How can countries, especially maybe building on the discussions we had earlier this morning, how do you see that really happening?
I mean, anyway, it has already commenced in part. Example, if you see round 1 of pandemic fund and round 2, clearly it articulated priority areas of pandemic fund is strengthening early warning, surveillance to health workforce. The last one, it was laboratory. And it says across this area, try to think how community health, it will play a stronger part on that, to the One Health approach. And the last one is strengthening institutions, including national public health institutes. Actually, it has already started there. So we have also other, I'm sure in the morning here also you have heard of this African ownership agenda, the political agenda now, in which our heads of state now have clearly said we have to take ownership of our health, we have to take ownership of our preparedness initiatives. And one of the issues everyone has already critically tried to think now is how are we able to include the preparedness actually in the national budgets. As a result, we start to see the movement. We need to actually see more. A problem is, yes, we have statements, the issue of implementation is always slow.
Well, building on implementation, one of the things you recently implemented was the preparedness data exchange. And I think we have a screenshot of this dashboard, a comprehensive dashboard that's AI enabled, where you bring together surveillance, climate data, other monitoring. Can you speak a little bit to us about your vision for this and what it will do in practice and what opportunities will emerge from this and maybe what challenges you see to implementing it or how it might be used best?
Yes, excellent, yes. I'm really glad actually to see it there. Therefore, the PDX, Preparedness Data Exchange, is our new innovation actually in which we are trying to see how AI it will be helping us in actually strengthening preparedness. So what we have really done is to try to integrate actually all the data related to all hazards here. I'm talking about climate-related hazards, I'm talking about outbreak, I'm talking about also crisis, humanitarian crisis and others, plus capacities. And capacities here, I'm not only talking about preparedness per se, as IHR core capacity, I'm also talking about primary healthcare capacities. And we have embedded an AI agent here in which it's helped us to have a real-time analysis of what is happening, okay? Because what is happening, as I've alluded earlier here, actually in Africa we have a lot of emergencies. As a result, we spend around 80% of our time responding. Therefore, we have 20% to think about preparedness. Therefore, the idea is how are we able to optimize available time in order to close the gap between alerts and decision making. As a result, we thought AI, it will help us. And also, two, we have fragmented sources of data. So we have EIOS example, you have all had epidemic intelligence from open sources, is from one source. And we have, for instance, SPA data from another source, and the hazard from another source, okay? And in order to bring all these sources, in order to analyze, to understand what is happening, it always takes time. As a result, here the PDX in which it enables us to bring all these sources together, to analyze it in real time. And actually, we've also linked it with the NASA in such a way we are having a real-time climate intelligence seat in which it will help us to see what is happening. So we've also added the political alerts inside in a way. For instance, if we have a coup d'etat happening in a country X, we have an AI agent in which it helps us to understand what is happening in the country as economic indices, in which how are they playing around, okay, stock exchange, how are they behaving at that. And at the end, it asks us, do we see an imminent threat here of humanitarian crisis to happen? As a result, we have all this together. And the last issue in which we've really done here, we have also added a large language model inside. In such a way, the Ministry now of Health or the Minister of Health is able to query. We have a place there, Ask WHO. Actually, you are able to query in the Ask WHO, actually, what are the strategies to immediately address a threat you are seeing, and you'll have the answer initially. Our aim is that instead of the ministries of health, every time they have a crisis to ask where is the WHO, we try to ask the Ministry of Health to have preliminary information in which it will enable to start action. Okay? As a result, the PDX is really trying to have an integrated preparedness intelligence in which the ministries of health are able to determine alerts in real time and actually take action immediately.
I know you would probably talk about AI a lot because you're an early adopter and very interested in its opportunities. Can I ask you, I mean, one of the potentials around AI is really in service of humanity, but there's also a risk with data and data ownership that it can really serve wealthier communities, wealthier countries. How are you thinking about safeguarding to ensure that some of the use of AI, whether through the PDX or other, is going to really benefit the African populations from where the data is actually coming? Is that something you're thinking about?
Yeah, we've already actually trying to do that. And actually in Afro, we have actually having another initiative. We have now created an AI framework for Africa in which it enables us to actually including ethical imperatives and other issues inside. And actually one of the issues we've all realized, I hope all of you realize, actually in one way or another, we will have to have a collaboration of Western countries because the technology is from there. We have to agree on that, okay? Our collaboration though have to be a win-win collaboration. Okay, for us in Africa, we have data. Where the data is from epidemiological data or even laboratory data, the pathogens data, etc. We have them. We have real needs. How are we able to have a discussion with our counterparts, see actually of the West, and see how are we able to collaborate in a win-win basis? I'm sure all of you have heard of INB negotiation, actually intergovernmental negotiation body in which you are trying to negotiate on pandemic agreement. It is actually in the premises we're talking about. If the West is able to agree on terms of the transfer of technology, example, to Africa to enable us to operate our tools, if the West is able to agree on collaboration on research and the development, okay? If the West will be able to agree to share actually experts, either in exchange terms or others, yes, I hope Africa will try to think and say, okay, if the issue is only have access to our data, we'll see how actually we're able. As a result, in short, is really about win-win. Because Africa will have a need, Africa will have data. However, we have to agree a technology is also from the West. how are we able to collaborate in order each one of us has a win is an issue in which we're promoting at the moment.
Thanks.
Yeah.
I'm going to pivot a little bit to talk about the health workforce and preparing the next generation. Many in the audience are either involved in medical education or public health education, and we have many students and students online. And how do you what skills or mindsets do you wish more graduates came into this work with? And what does the World Health Organization, at least in preparedness and response, need from academic institutions, whether in the global north or on the continent, that you're not currently getting?
Yes, actually, it's really, really an excellent question. Actually, in the year 2022, Africa created an African Health Emergency Strategy 2022-2030. And one of our priorities in the strategy, it was on how to strengthen emergency health workforce. Okay, and after initial years of implementation, we realized we have a fragmented emergency health workforce cadres. We have, example, emergency responders, we have epidemiologists, there's a field epidemiologist, we have a plethora of actually training modules in which are out there. And actually last year we agreed, we tried to bring together all the cadres, actually all of the disciplines, including EMT, emergency medical teams, together and create Global Health Emergency Corps. And under the umbrella of Global Health Emergency Corps, we created, or we are creating now, an African Health Emergency Corps, okay? Now, a problem is we still think we only have the people who are graduating from school who they haven't had any training on emergencies, are only coming in emergencies. We are trying to train afresh. So in the future, what we are really thinking, how about integrating emergency curriculum actually into health professionals, for instance, in the medical school or in the nursing school, etc. And we've already started exploring the interest among our member states, and it looks clearly they have a strong interest on that. So I really feel our issue now is to understand what kind of a curriculum of emergencies have to be integrated at which level. In my side, I'm more interested on strengthening emergencies, capacities, and skills among community health workers. Because in the WHO, we believe emergencies starts and end in communities. Therefore, it would be appropriate to see how are we creating an emergency-ready communities in which it helps us in either identify the abnormal trends in the community and actually trying to refer it to the appropriate authority. So academic institutions, you have a role there because I hope you'll be actually able to help us in even creating a curriculum of emergencies itself, or even trying to create a training program in which it will help us to actually include. Yes, another area you will help us is a research. On the research on how do you think we should structure our research, identify appropriate competences in which, for example, a community health worker have to have, or even a nursing. And actually on the last part, I feel is evaluation of the training models, because now we have so many training models out there, and really we don't know actually which one has higher impact over the other. Okay.
Great, thanks. Can we talk for a minute about One Health? So countries across the region are facing numerous threats, and you mentioned 100, 120 emergencies every year. And many of those threats are really at the intersection of human health, animal health, environment, the planet, climate. How is WHO Afro advancing the One Health approach, and what might it take, do you think, to advance from the conceptual alignment on the issue, which again is sensible, but sometimes in operational pragmatism is challenging.
Okay, an excellent issue, bringing it here, and I hope all of you understand. Last week we had the Global One Health meeting in Lyon, France, in which it was organized by the government of France and also our president from actually Ghana. Okay, issue is One Health. The WHO is the part of a quadripartite collaboration on One Health. A quadripartite is actually a platform in which UN agencies, FAO, WOA, the UNEP, and the WHO are coordinating the One Health. And what has happened ever since is really trying to come up with plan of action of One Health, the global strategy plan of action, in which in the WHO Afro we have tried to come up with a regional plan, and also trying to emphasize in the country level to create also the national plan, including a coordination platform, the One Health coordination platform, having actually interoperable surveillance systems between animal and human and others. Actually, implementation is uneven among the countries, honestly speaking, and also we are supporting the country to have a national bridging workshops in which we are having animal health expert and human health. A problem or an issue we have in Africa is that at the moment Africa have a really a complex the landscape in partnership. Therefore, as I say, the One Health is coordinated by the UN agencies. We have other agencies in Africa in which also are prominent in the public health emergencies area. I'm talking here about Africa's CDC, I'm talking African Union Humanitarian Agency, I'm talking about REX, the regional economic bodies like SADC, like East African Community, WAHO, and others. As a result of that, we are trying now in Africa to see how are we able to bring everybody on board. So we have two actions ahead of us we are trying to see. Action one is actually to create a continental task force on One Health, in which we bring everybody on board. And action two in a WHO specific, I'm trying to think if we'll have the One Health resolution in Africa, with RC. We've been talking of One Health globally, but there is no any global resolution in the World Assembly on One Health. As a result, Africa, we are trying to create that, okay? And if we will have the ministerial endorsements, I feel it will be an excellent step now, because, I mean, actually, we will have obligations on their side. Yeah.
Yeah, we talked about the declarations and then the implementation, but the declarations are helpful to move the implementation forward too. So let us open it up to the audience a little. So if you have questions, please raise your hand.
Yeah, thanks. Great talk. So my question is, how do we get, or is it worth considering getting from response to preparedness to prevention? And of course, global health does prevention with vaccines and so forth, but I'm specifically talking about climate change. And I'm wondering, from your perspective, Dr. Chamla, is there a role for public health professionals, for health professionals, for climate change experts to, but in particular in health, to work on prevention? And if so, who should do it globally? Should it be the wealthy countries? And how should they do it? How should we prevent the crisis that is affecting your countries the most for climate change and health?
Do we have any online questions? We'll take one more and then.
Yes, we have one online question which asks, how can international policy frameworks better support such grassroots AI innovations to ensure long-term sustainability and resilience in African rural communities?
Yeah. Okay, any other question? Oh.
At the back.
Yep.
Thank you so much again for the great discussion. So my question is actually linked to the countries affected by conflicts and instability. So from your perspective, the WHO perspective, how are you envisioning the aspects of interacting with non-state actors with the non-state actors in the efforts linked to preparedness and response, generally speaking, for emergencies? And another element linked to the protracted crisis-related aspects. So you said, you are looking at the preparedness as a stage for development activities as well. So how are you currently engaging, with the different countries across the health ministries? For example, with primary care, the aspects linked to the tertiary, specialized care as well. And it's interlinked with the emergency preparedness efforts. Thank you.
Okay, that's a lot to chew on.
Yes. So we have another one there. And actually, it's all tough questions. Yeah.
Hi, Jessica Haber from Mass General again. So my question is very similar to what Anmar just asked about coordination of different institutions, ministries of health, et cetera. And you started to get to that point with the last discussion on One Health. But with regards to Africa CDC in particular, I'm wondering how the WHO is engaging with that as a coordinating body across the continent. Thank you.
Okay, so climate change. Yeah, climate change, who will lead that, who will be able to help us? It's really an interesting question, because in the WHO, we have two things in which we are trying to talk. We have one thing in which we are managing in emergencies teams. We have another thing in actually another cluster. And here I'm talking really climate adaptation or climate mitigation, climate change mitigation. Therefore, to us in emergencies, we are really talking about adaptation more, okay? Because we think our capacity, our mandate, it allows that. Because the impact of climate change in emergencies, it isn't only on increasing frequency of flooding or actually on the natural disaster. We have another impact of climate change in emergencies. We are slowly seeing epidemiological change of the occurrence of our outbreaks. Actually, Marburg, it didn't happen actually in the past in Ethiopia or even Tanzania. It happens now. The reason is simple. We are seeing a migration of birds and insects out from actually normal places or the normal habitats in which we're there. As a result, here is actually our concern for us in emergencies, and is a reason we decided actually climate adaptation, it is our priorities at the moment. We are also collaborating with other institutions to do that. However, how are we able to influence for instance, the impact of climate change in which is coming from another countries is always outside. It's really outside our scope of work. However, we have other agencies in UN, UNEP, for example, in which role on that. And is the reason we have a platform of One Health, in which it has also included UNEP on that, okay? And how have we been able to engage grassroots? It's an issue in which has repeated over and over. And I think one of the issues we have already talked at the time we're creating our AI strategy is actually to have a peer review of our strategy. And in the peer review process, we've included actually the people at the community level. And our issue at the moment in which we have encountered is actually at which level are we able to actually bring in the people at the grassroots level. As you know, AI is highly technical area. Actually, it has coding issues, et cetera, et cetera. As a result, it was only that. And at the end, we agreed we would be able to bring grassroots level on the issues of ethics, applicability and uptake in the country. And actually on the last issue, it's actually to hold the government accountable. I mean, actually in its implementation. The conflicts, yes, is really an interesting issue here because the WHO, as you know, is a UN agency. We are operating under actually a framework of international humanitarian laws. I'm sure all of you are aware of that. Globally, we have cluster approach in which we've agreed to implement from a time of humanitarian reforms in which happened in 2005. So in humanitarian reforms, WHO had a role as a health cluster lead, okay? And our involvement with the government is actually on the issues associated with actually health in crisis. A problem in which we have encountered is if the government is a perpetrator of the crisis, and actually how do you operate that one, okay? Me personally, I've worked in actually under Taliban. And even I started prior to Taliban. So we had Taliban actually overseeing an area of work closer to half of the country at that time. It was under Taliban. And actually the other half under the actually a normal government. And if you're talking of the prevalence of, at that time, of the polio, actually predominant areas of polio, it was under Taliban area. As a result, to organize a campaign of polio and others, we have to have access to that how do you call it at that time, a rebel group, Taliban at that time, okay? Mean to have access. As a result, we are trying that because we feel that health is a right of everybody. As a result, we have to work even across the non-state actors. So we have a framework in which we are operating, how to negotiate or even how to have access to non-state actors, actually in which we are operating with. On the protracted emergencies, I mean, I'm sure all of you I'm sure you remember, I think it was in 2016, we have humanitarian conference in Turkey, in Istanbul, and in which one of the issue in which it was brought, it was humanitarian development and the peace nexus, okay? As a result, in the protracted emergencies, it's a place in which we have already started implementing that. Therefore, in the WHO Afro, we have created a framework of health in humanitarian development and the peace nexus in which we are actually operating. An issue here now in protracted emergencies, we have to have also a strategy on how are we able to integrate our emergency issues into a development agenda. Therefore, we don't have enough time. Yes, we have an excellent collaboration with Africa CDCs. We have a framework, it's Emergency Action Plan, it's called. Now we are trying to include other actually areas of work like health systems and others. Yes, but it isn't as rosy smoothies. We have some hiccups here and there. We have to admit on that. We have another platform on actually continental IMST you have heard, in which it was created at the time of MPOX. We have small issues happening here and there, particularly on the declaration of public health emergencies. As you know, globally we have IHR Annex 2, article in which we say clearly we have public health of emergencies of international concern. Under another article statute of African Union, we have another actually declaration at the regional level. And the last 2 weeks we were in Johannesburg. I tried to bring everybody in Johannesburg to see how are we able to align in between the regional declaration and the international declaration. So I should end up here, I think.
Yeah, well, thank you so much. We really appreciate your expertise and spending time with us. Thank you, everybody, for your engagement. And please join me in thanking Dr. Sonia.
Thank you, Dick and Louise, for giving us quite a clear example of what moving forward can look like. We have spent the morning looking at resilience, systems, financing, and now we're going to turn and speak about the people that make things happen. Our next session is Training Tomorrow's Healthcare Workforce, the role of academic partnerships in health system strengthening. This session is a special collaboration with our partners at the Department of Global Health and Social Medicine at the School of Medicine. To frame the discussion, please welcome to the podium Dr. Joseph Radigan, Associate Professor of Medicine and Paul Farmer Chair in Global Health at the Brigham and Women's Hospital here in Boston. Dr. Radigan is also an Associate Professor of the Department of Global Health and Population at the School of Public Health, and an Associate Professor of Global Health and Social Medicine, and Director of Curriculum Development for Global Health Delivery at the Harvard Medical School. Dr. Radigan, please join me.
I'll invite our panelists to come up. So as you all know, people, the healthcare workforce, are essential to any well-functioning health system. And well-functioning health systems ensure that their healthcare workforce have the skills and the supports needed to do their jobs. Unfortunately, we're facing a very large deficit of skilled healthcare workers. This is due to many issues, including the aging of the global population, increased burden of disease, more people living with disability, the underinvestment in health professional education and health workforce training, and frankly, the untenable job situations many people find themselves in with burnout and health systems having a hard time retaining skilled healthcare workers. As we seek to improve global health equity, we will need to find innovative ways to increase the number of skilled healthcare workers. And that is what today's panelists will be discussing. I would like to now introduce our speakers for this plenary session. Professor Abebe Bekele, who is the Deputy Vice Chancellor of Academic and Research Affairs and founding Dean of the School of Medicine at the University of Global Health Equity in Rwanda. Dr. Shriram Samasunda, Professor of Medicine at the University of California, San Francisco, and co-founder and faculty director of the HEAL Initiative. And Dr. Apara Parikh, Associate Professor of Medicine at Harvard Medical School, gastrointestinal oncologist and director of the Global Cancer Care Program at Massachusetts General Hospital, and Dr. Ingrid Bassett, who will moderate today's session. Dr. Bassett's a professor of medicine at Harvard Medical School, an infectious disease physician at Massachusetts General Hospital, and the co-director of the Harvard Center for AIDS Research. Ingrid.
Thanks so much, Joe. We're really excited for this panel to be standing between you and lunch. No, I'm kidding. We're really excited about this panel because I think today many of the panels are focused at an extremely high level: governance, priority setting, emergency preparedness. This panel, I'm excited we're going to be able to delve deeply, hopefully into the technical aspects of health system and health workforce strengthening across multiple models. We have our panelists focusing on different areas. We have Abebe working as a dean in rural Rwanda, trying to quadruple the healthcare workforce in 4 years, a big goal. We have Shri as part of the HEAL Initiative, training cohorts of healthcare workers across different healthcare cadres, community health workers, physicians, nurses, to try to build capacity in rural areas and try to promote professional development and retention in the workforce. And we have Aparna specifically focused on the oncology workforce, medical oncology, radiation oncology in Africa, really trying to develop African oncology leaders. And while these are different, I'm hoping what we'll come through this panel with are some of the common threads that really help inform how partnerships for training and healthcare workforce development, how they should look, and how they should be, their architecture to be the most effective. So I think we'll go ahead and start with Abebe. I think I'm going to ask each panelist to set the stage a little bit in terms of, you know, how workforce depletion shows up most starkly in your context, and then we'll spend the rest of our time sort of focused on how you're addressing that. But can you just set the stage for us?
Thank you. So happy, so proud to be among us today. Thank you for the invitation. I can mention two things. One is you probably will have a lot of patients in your waiting list. I'm a surgeon by training, so one manifestation is a lot of patients who do not have access to any sort of care. Second would be, I'm also a dean of a medical school. You are trying to recruit qualified people to a certain position. The vacancy stays open for months and months, even years. You have to look at other ways of filling this position. The third might be from a policy perspective is you look at really difficult policies to understand coming out of ministries. Intense focus on task shifting and task sharing instead of focusing on producing the right professionals. The sudden explosion of medical schools in a country. 5, 6, 7, 8 times fold in a few years. That is a sign of a chronic deficiency of workforce in a given setting.
Thank you. Shri, how about you?
Sure. So yeah, thank you for having me. So the program I run is at the University of California, San Francisco. It trains different health workers across many different sites. So Navajo Nation with indigenous health workers, rural Californians, as well as 9 countries around the world. And I think one of the things that we see over and over again is that in all of these places, health workers, they're too few, they're undersupported, they're overwhelmed. And so the structural instability and the structural violence of the health systems, the natural kind of outcome is people making decisions to leave, to not be retained. I think Joe mentioned burnout and the moral injury that comes with doing this work and not being supported and not having a pathway to grow. And so I think the consistency across all of these geographies that I see is remarkably similar.
Thanks. Aparna, how do you think about this as it relates to specialty care?
Yeah, I mean, so just to level set for those of you who may not be aware of the cancer statistics. So when you look at the cancer burden, around 70% of the cancer incidence and mortality is happening in low and middle income countries. And when you look at just the workforce, so just pretty stark numbers. So in Boston, we probably have 200 to 300 oncologists per 1 million. And I think if you look in parts of Africa, we're talking about 1 in 1 to 2 million. In terms of just access to even facilities, if you look at radiotherapy, for example, less than half of African countries have access to a working radiotherapy unit. Oncology in particular, I think, is incredibly challenging because it requires multi-subspecialty care, it requires pathology, it requires diagnostic capability, it requires surgeons, radiation oncologists, medical oncologists, noting that in the African training model, many of the medical oncologists are actually the ones also delivering the radiotherapy as well. And then, of course, the importance of the palliative care as well, since the majority of patients are actually diagnosed with late-stage diseases. So I think we're starting to chip away at parts of this, but I think the continuum and the spectrum of care required for oncology patients is incredibly complex and a tremendous deficit in terms of just resources and limitations.
Super, thank you. I'm hoping that you can each describe a little bit about the models that you have developed to address these gaps, specific training models and partnerships, and really thinking a little bit about how these are designed to address the gaps that you've just described. You can go ahead. We'll start with you, Sri. Go ahead.
Sure. So, you know, I kind of came of age working with Partners in Health in different settings, and I was in Haiti after the earthquake, and I think one of the stark things of seeing, you know, after the earthquake, even months after, kind of thinking about Haitian capacity building as an afterthought instead of kind of at the forefront. And so we started HEAL in 2015 and really started working in Navajo Nation and many other countries around the world. And in Navajo Nation, which is an indigenous community in the southwest of the US, there's a 30% vacancy rate. And oftentimes, you know, they're using temporary staffing to fill their jobs. And so what we did is we basically combined, you know, early career physicians coming out of residency that wanted to do social medicine, wanted to commit themselves, and we had them share one job in Navajo Nation. And instead of that money going to a temporary staffing company, it came to HEAL, and we supported 2 Navajo health workers, 2 Malawians, 2 Rwandans, and some US, you know, post-residency fellows. And so the model is really about interprofessional training. So we have community health workers alongside nurses, alongside doctors. I think that's super powerful, as well as you know, training in rural settings. So having workforce and programs that actually exist, because we know that where people train is where they remain. And so I think those are some of the innovations, and then obviously trying to in our programs not be have some of the voyeurism of doing international work, but combine it with a domestic commitment as well, and then trying to have a model that makes use of poorly used market failure government funding to cross-subsidize the work.
So some cost sharing.
Yes.
Okay. Baby, I'm wondering if you can talk about the model that the university has taken on. I'm thinking about the kind of structure of the partnership. A lot of people, you know, coming into Rwanda, and how you think about that, how you kind of manage the partnerships, which are quite extensive and I think really important to the success.
I work for the University of Global Health Equity. This is a university 2.5 hours away from the capital city, Kigali, deliberately placed in this rural part of Rwanda called Butaro. Behind us is a district hospital. In front of us is a green space, completely rural, after a concept called place-based education. We expect graduates of any medical school to go back to a rural community and serve after graduation. And yet we criticize them when they can't. They burn out after a year, they decide to leave the job and return back to where they came from. One of the reasons is because they're not prepared to serve that role. What you try to do is, what if we train them in the real rural part of Africa? It takes 6.5 to 7 years, and they graduate with 2 degrees, their medical degree and a degree in global health delivery, a master's degree. We're trying to prepare them to serve that specific role. In the district hospital, they're supposed to be leaders. Many of them are medical directors, sometimes the director generals. At least they lead a certain healthcare system. Many of our graduates sit in the ministry, including the state minister of the country. We are trying to prepare them specifically for that role. And they also need to be really good doctors. General practitioner in Africa serves a different purpose than the practitioner you know probably in North America. Internship is not the first-year internship, residency program. Internship is junior doctorship. By the time they go to a district hospital, they take care of everything. Surgery, maternal health, pediatrics, emergency, you name it. So we are preparing them really well to serve that role. How does the partnership come into HGHI? In fact, it's a classical example of what governments and NGOs can do if they really work together. The partnership between the government of Rwanda and Partners in Health is really amazing. The direct support we get, the free land we enjoy from the government, the open door policy with all the ministries, including the High Office, the day-to-day encouragement, the support is really valuable and really instrumental. Partnership with funder institutions is also instrumental. A classical example that non-vertical funding, transformative, substantive funding can actually bring about good change in academia. And then the way education and research is delivered at HGHI is also partnerships based. If you look at the definition of global health equity, it's about products, partnerships, and processes. Without partnerships, there is no global health equity. And that's why we carry the name global health equity. Partnership is a key pillar. So we work with whoever is willing to work with us, provided we share the same value. And the value is equitable access to healthcare, particularly to the vulnerable, to the underprivileged. And we work with a lot of academic institutions in the world.
Thanks. Should we go ahead? I'm just thinking about your sort of training model.
Sure.
And how you think about that across the different workforce cadres.
Yeah, I think our model has shifted over the years where, I think we have 5 pillars that we focus on. So at first we're interested in teaching some of the clinical competencies, but we realized that, a lot of, if you're working in rural India, the local workforce there, the faculty there are much better at teaching TB, for example. And so we've kind of shifted our work into very specific social medicine pillars. So really around leadership, around structural competency, advocacy, well-being, this idea of understanding your power and position as a physician, to both from a standpoint of leveraging that power, but also having humility. And so those are the 5 pillars. And what's been incredible to watch is the case studies that have come out of the clinical scenarios that exist, in real time that our fellows are dealing with, and turning that into cases to learn across this shared network globally. And so we just had a global health book called Illuminating Global Health that got published, and it's fascinating because it's cases from Haiti, Chiapas, Nepal, India, Navajo Nation, and it's really a collaboration between very rural committed workers from those communities, bringing clinical cases and then combining them with social scientists that break down kind of the structural reasons people get sick, why this outcome happened, and then I think that's an example of just having an education that is informed from the ground up in our curriculum.
Thanks. Aparna, how do you think about this for specialty care? I know one thing that always would worry me in South Africa when I wanted to meet with people, say, boarded in infectious disease, it was a very limited number, and every time we would pull them away, we felt we were sort of robbing Peter to pay Paul, so to speak. And I'm just wondering, can you describe a little bit about your model and how that works?
Yeah, 100%. I mean, I think we're very acutely aware that we don't want to contribute to the further resource drain that is already facing and workforce drain. So I think, what we did, back at around 2016 or so, at a meeting, a cancer meeting in Africa, we started to have conversations with 2 of the larger training institutions. So one, the Ocean Road Cancer Institute in Tanzania, and then the other, University of Cape Town, that was training, oncologists, a large proportion of the oncologists. And I think what was very explicit with the training programs is they felt that the opportunity to spend some time with us looking at not necessarily just the access to novel therapies and things, but just very practical things, dosimetry, chemotherapy safety administration, quality and safety metrics, how do you set up tumor boards, very, I think, practical type of information that they thought could be delivered in a concentrated format. I think 2 things that came up consistently was, one, the time. I think, how much time did they want people to spend there, because it was going to hurt their own patients and their own staff if we had them come for too long. And then second, letting obviously them kind of pick who they wanted to come, with very much intentionality around who were the people they thought they were going to stay and lead in country, right? So as best as you can pre-select those folks that would be the next generation of African cancer leaders, allow the training programs to select who they think that might best benefit. So we started in 2017. We had, pre-pandemic, around 8 to 9 come and spend time across a couple of the different Boston hospitals. And I think what was really valuable was not only the exposure, but I think that the networks and the access to people. And I think we were very intentional around mentorship too, even for grants. And many of those early kind of fellows subsequently ended up getting, various career development awards and NCI grants, and have maintained kind of connections with Boston-based faculty too. I think the other thing, it was a little bit cringy for me, because we'd have these Boston oncologists dial into some of the tumor boards, and you're so out of context in terms of what is available for patients there. And so what we were able to do amongst the fellows that consistently came was create a community of practice amongst themselves. And so they can look to each other to provide case support and management. And we're always there to provide help as needed too, and frequently get asked to weigh in, but rely on each other. I think they have the smarts and the wherewithal entirely to kind of help guide each other. So create a structure for them to be able to communicate with each other. So we've slowed down post-pandemic just for various reasons, but I think still really has been anchored around partnerships with the training programs.
I think that for us to, the community as infrastructure and belonging as infrastructure, because a lot of these rural health providers are just, they're not getting the support, or, the academic centers that might be in Boston or San Francisco can't provide them the context that they're living in. And so having this shared cohort, this global solidarity across, all these health workers, I think has been core, and it allows people to sustain in the work too.
Yeah, I was thinking about the HEAL cohorts as you were talking, in terms of the previous cohorts serving as resources for the current cohorts, and the kind of training the trainer, that aspect of HEAL, I think has a certain resonates here as well. Okay, well, we're going to pivot a little bit to talking about how you align the training with the populations you're serving and the systems where you're functioning. And so thinking a little bit about how you kind of anchor your programs into the everyday reality, in terms of how you're defining the needs that you're aligning with. And, Aparna touched on this a little bit, like balancing, the realities of what might be available in a rural or low resource area with what international training standards are. So I wonder if you could talk a little bit about defining the needs, and then how you're balancing that.
Well, thank you. I guess you were talking about curriculum. One of the issues the continent of Africa has is it is yet to define the kind of doctors it wants. Are we following the North American model, the European model, that is probably 100 years old, and copy-pasting it to Africa? Or does the continent, has it yet identified the kind of practitioner it wants to serve its purposes? What is the job description of the doctor? We don't have that. The job description leads you towards the competencies. What are these doctors expected to do in terms of the domains, knowledge, attitude, and practice? We still did not have that. So the very first struggle we had at HGHI was trying to define that. Assembling the right expertise, looking at the burden of diseases in Rwanda, what are the common 10 diseases, 20, 30 diseases, how do we create curricula, syllabi out of that, and then create the content. It took a bit of time. It's still an ongoing process. Mm-hmm. Luckily, I'm glad our colleague from WHO Afro is here. For the very first time, a couple of months ago, WHO Afro took leadership in owning curricula in the continent. They rolled out 10 curricula for the very first time. It's still a work in progress, but that's step one. Now, once we identify what these doctors, practitioners are supposed to address in the country, dealing with the knowledge that's in the practice is reasonable. Mm-hmm. The second challenge is, do we have enough expertise as faculty, as mentors, as teachers to deliver the content? Unfortunately, the answer is a no. And not just in Rwanda, it's across the continent. So we depended a lot on partnerships. Partnerships are not gifts, are not donations. These are bilateral things. HGHI had strong relationships with Harvard since the very beginning. From its inception, its visioning exercise, curriculum development. So it's natural. Being an implementing partner was not difficult. The key was the shared vision. Not the key goal, but the key vision. Why are we partnering? To achieve what? It's not to produce doctors, but what do the doctors do? What is the ultimate vision? It's about the vulnerable, it's about the poor, the underprivileged, equitable access to healthcare. So that is how the defined competencies fed into the partnerships we have.
Thank you. Okay, Shri, I'm wondering if you can also think about this in terms of how you are keeping your work anchored in the populations that you're serving, and also, any feedback you've gotten from partners that has then changed the way you do business. And you alluded to this a little bit, this sort of progression or evolution from your initial model till now.
Yeah, I mean, in terms of the clarity on who we partnered with and why we do this work, the goal is to train health workers that are accompanying resource-denied populations, poor populations, and stay in this work for the long term. And so I think our program has definitely evolved in a big way, in that a lot of the now we have several hyper-local cohorts around the world. And so we have a cohort in Mexico that's in Spanish. So one of the responses from some of the early Mexican fellows that were counterparts, they came to the US, they did some training. A lot of them said, as powerful as this work is, there's my counterparts that don't speak English, don't have a passport, that are in the public sector that would benefit from this training. So they've adapted kind of the pillars of what HEAL started with and made it specific to their context. And same in Navajo Nation, I think there's been a lot of Indigenous women that are alumni of HEAL that feel like the way we mentor, the way we need to integrate Indigenous ways of knowledge need to live in that cohort in a specific way. And so they've indigenized the curriculum, they've adapted the mentorship for their context. And so now it's mostly Indigenous HEAL alumni running a cohort for Indigenous nurses in Navajo Nation and Zuni Nation. And so I think that essentially it's just living in the work and evolving the work based on what our counterparts across the world are telling us. And I would say those are some of the adaptations. I think when the U.S. providers, and this is probably consistent in, when people practice in capital cities. One of the, one story was our rural Indian faculty lead was telling us that some of the U.S. doctors that would come to India were pushing a lot of the patients into debt because they would come in and they didn't have the context, and they were saying you should get this CT scan because they would order that CT scan in San Francisco, and the patients would comply, go sell off their land, or and so there's a lot of I think being responsible and responsive to the context that you're serving, and ideally it being driven by the people closest to the work.
Super. I wonder, Aparna, if you also can talk a bit about the population health priorities and that tension with the everyday service realities.
Yeah, I mean, I touched on this a little bit, but to dive a little bit deeper in terms of just the priorities, I think every training experience is really fit for purpose. I think based on where they're ultimately going to go practice, what disease areas. Breast cancer obviously comes up as a #1 tumor type that they want a lot of exposure to, so we ensure that we have that. And then not only working with the trainees that are coming, but the programs to really bolster, what are the other skills that I think can help strengthen just the cancer care delivery model, that some exposure could be useful. I think one practical example of this, one of the Kenyan oncologists who was very interested in clinical trials and how to set up clinical trial capacity, particularly with some industry-sponsored trials. So spent a lot of time with every function role group around the clinical trial pipeline. So in cancer clinical trials, there's regulatory, there's the budgets that are really important to build some infrastructure in a health system as well. And so I don't think we had a one size fits all. It was really sort of tailored based on what the need was at that time and what they were hoping to get out of the time here.
Thanks. All right, we're going to turn a little bit to the kind of concepts of equity, reciprocity, and sustainability. So we've heard a little bit of this. Abebe said, this is a two-way partnership. But I'm wondering if you guys could speak a little bit more about the partnerships in terms of how you bake equity and reciprocity into them, and any of the kind of design choices you made to keep the power balance such that both sides are seeing the benefit and not feeling neither dependent nor in control, but really in true partnership.
I guess I can start.
Go ahead.
I can mention a few things, and but I'm sure my colleagues will add on to that. I think the very first thing is the shared vision. You can't partner with a group or an individual you don't share a vision with. It's not about doing this job and then part ways. It's a journey. It's a long-term journey. The second is, I think the friendship is critical. That fellowship, that friendship that predates the partnership is really, really helpful. That trust building. Mm-hmm. This decision is on my favor, on my behalf. I trust this partner. That is critically important. During the partnership process, conflicts will be there. Misunderstandings pushbacks will be there. But if the friendship and trust is there, it's easy to navigate this. It's easy. The third is it should indeed be a partnership. At HGHI, we receive several visiting faculty from universities. It's not just the teaching. They are part of the department. They join the department meetings every month. They are in the curriculum planning team. They are consulted during exam preparation. They are consulted during graduation. Most of them are invited to graduation. I hope we could afford to pay for tickets for everybody. Because they are part of the institution. So they should be part of the decision-making process. Mm-hmm. These three I have found very, very important. Maybe one last point would be partnerships don't end. I guess they transform. It would be probably a bit naive to think, it's for a 5 years thing, I'm done after that. If there is friendship and trust, I don't think it's going to turn out that way. The partnership morphs, changes into something else.
Thanks.
I would say, some of the language and practice, like the rhetoric of global health partnerships, kind of outpaces the practice and the living into solidarity, solidarity as a verb, and really operationalizing equity. Because, we talked about solidarity as risk pooling, and I think most academic medical centers in global health have come up as serving kind of the US trainee in some capacity. And so to actually live into work that doesn't replicate those systems and those power dynamics, I think is very difficult. And oftentimes the language of what we hold up and the actual reality diverge. And so I would say for us, it's, trying to have governance around, who gets to decide how the program unfolds. For example, I think some of our local fellows or site fellows, the community fellows that joined the cohort, they would say that, how come we don't get to travel, right? And so there became these exchanges where a lot of Haitians went to India and Indians went to Nepal and Nepalis went to Liberia. And so there's this cross-collaboration that came from their voices, right? And then I would say that, in global health, there's phenomenal programs and faculty, but oftentimes we need our institutional partners to have the institutions we live in to have skin in the game. And I would say that, in our work in Liberia during Ebola, we had a program that was running there. And, I think the risk aversion of the institution was they wanted to pull back, right? And we see that time and time again. And so we need kind of the level of academic medical centers to live into, because I feel like power analysis and the ability to take on power is a core global health competency. So you need your institutions to support when you're operationalizing in that way.
Super. How about you in terms of thinking about the reciprocity, the sustainability?
Yeah, I mean, I think as I was mentioning post-pandemic, one of the reasons we slowed down a little bit was a pure ask of the training institutions. So they said, I think 8 is getting to be a lot. It's a strain on us to send 8, so we still want to send, but can we just come down to 2 or 3? So kind of a small example of that. And I think what you said really around the friendships is so beautiful, because these partnerships and friendships grow over decades. And I think, from our perspective too, it's also just the sponsorship of these young oncologists in the global context. And so, if it's coming up at our American Society of Clinical Oncology meeting, who do you want to put on the podium for a talk, and who do you want to put on an editorial board to get some representation on editorial boards? And so I think it's not only in the moment, but I think it's that long-term partnership of how you can promote and kind of sponsor to continue to develop the African leaders.
I'm glad you touched on the scholarship piece. I'm a researcher, in my heart, and and we might get questions about this later from the audience, but just, I think part of the reciprocity and equity is that people locally are generating the knowledge and are having the opportunities to shine on the global stage, at conferences, in manuscripts and so on. So I'm glad that came up. The kind of authorship piece, the career advancement piece, I think it's really important, and that is the kind of really walking the talk. All right, I want to look ahead a little bit, and so thinking about designing these partnerships, for impact into the future, kind of taking a step back from, the problems you've solved and where you are today, and really thinking about, what might need to change structurally, politically, in another way, so that these academic partnerships are ready to take on the future for the healthcare workforce, which could include, AI or other things that are coming down the pipeline, which will inevitably change healthcare. How do you see the future for your partnerships? How should they evolve?
I guess the future of global health will be partnerships. Without partnerships, there will not be any global health. So far, things are fine. The past 10 years have been really...
I'm glad you feel that way.
I'm very optimistic, because I am a real beneficiary of what partnerships can achieve. We work with quite a number of academic medical institutions from the US, quite a number. And most have been very productive, equitable, power-balanced, productive. So I don't think I have too much to complain about partnerships. I think the future is going to be partnerships. In fact, what needs to change is we probably need to look internally. It should not just be north-south partnerships. The north-north collaboration partnerships are really meaningful. And that is why last year, the University of Global Health Equity, together with our friends from HMS, convened 115 medical schools in Rwanda. This gave rise to the formation of the Consortium of Medical Schools in Africa. At the moment, 71 medical schools are members. Wow. The next conference is going to be in July in Addis Ababa, maybe next year in West Africa. This is the inception of the American AAMC, which is 150, 60 years old. So partnerships, even though really, really beneficial north-south, we need to look at south-south. because there is a lot we can share. Most African countries, the same burden of disease, same issues, same opportunities, same future. It's a youth-dominated continent.
Yeah.
It's only reasonable, logical, to find solutions together.
And potentially the solutions to the issues you brought up earlier around like a common curriculum and what should the job description for a doctor look like. And so it may be that COMSA is the way forward for that. Super. Shri, how about you? What do you think? What needs to change? What do you see in the future?
I mean, I like what Abebe said, because HEAL partners with the UGHE. I think UGHE is one of these models of the Global North institution essentially, has to line up with the priorities of what the needs are with the UGHE. And that is obvious, but that doesn't often happen in global health. And so seeing more partnerships where it just, it feels like a level playing field. You still have too many very short-term fly in, fly out. You're not responding to the global burden of disease, what the health workforce needs, and the agenda set in the global north in an academic institution very far away from the setting that you're working. So potentially seeing more UGHE-like partnerships where, when our fellows go, it's a very clear, this is what's needed in Rwanda, in Butaro, in this context, this is how you're going to contribute. And I think that's important in all of our partnerships.
Super, thank you. Arna.
Yeah, I mean, cancer can be a little bit overwhelming, I think, to think about because of, all the people that hit a patient in their journey. And, as we were just having this conversation, I kept kind of thinking back to man, I wish we could really figure out something for just oncology nursing, right, in a more systematic way and what an impact that would have. And was thinking back to, 20 some years ago, some time I spent a couple years in Eldoret. And I think Butaro is the same now. I think, actually has, true oncology services. But in the start, at some of these places, it was, the just general medicine folks, giving the chemotherapy and trying to understand. And I think we can aspire to having a growing oncology workforce, but until we get there, we still need to care for the patients. And so how do we continue to support the other role groups that are going to be touching the patients. And I think that's my sort of wish list of trying to get there, but that's a big task for all of us to think through together.
Shri, can you maybe comment on that just in terms of, I think HEAL, uniquely focuses on multiple healthcare worker types and how you came to that, because it sounds like that could be very helpful in oncology care. I just wondered if you could reflect a little bit on how you got there and how they interact with each other.
Yeah, I mean, I think physician training often, in so many parts of the world, is kind of you're disconnected to the populations that you're serving in some ways, and even if you trained in Mumbai, for example, you don't really have a great context as how your patients live their lives, potentially, if you've come from kind of a more middle class or upper class background. And so really, the doing home visits, for example, accompanying community health workers, that's where the greatest learning happens. And so oftentimes our cohorts have, just nurses and community health workers and behavioral specialists, and that richness of different lived experience and how that informs how we practice medicine, because there is being an excellent clinician, and then there's actually being relevant and useful, because all medicine is delivered locally, right? And so really understanding the populations that you're serving and some of the structural violence and structural challenges that those patients have. I think having mixed cohorts where oftentimes, the CHWs that join the cohorts have 10,000 times more knowledge about delivering healthcare than somebody who trained in a big city. And so having them benefit from seeing themselves in you because they're in a room with a physician, and that sometimes is not useful, and they realize like they're just as incredible as, and so some of it is just holding a mirror up to phenomenal leaders that kind of can see themselves as phenomenal because they're now in a global conversation, because they're in a room with different cadres of professionals.
Maybe I would add one other thing I think it's important for oncology, and is sort of how do you layer on to existing kind of primary health services too. I think there's such a late stage presentation, and one of the Brigham docs, Lydia Pace, has done some really nice work around breast cancer screening on when you're coming into to care for other reasons too. And so I think one of the key aspects, I think we're focusing a lot on treatment, but if you go back to my initial numbers, most cases are diagnosed late, and so how can we provide awareness, education, kind of stage shift, so you're getting earlier stage disease, and a lot of that is education and opportunities to layer on to existing, existing health systems and primary healthcare services as well.
Yeah.
Do you want to comment?
I don't think I'm going to be helpful, but let me try to complicate the situation further. I'm a surgeon, so I am closer to the surgery numbers. When you look at the SAO, surgeon anesthesia obstetrics density, this is a figure WHO uses. The minimum expectation is 20 per 100,000 population, preferably if it's 40 per 100,000. And just to give you the context, if you go to the American College of Surgeons website and check, it's 48.1. And yet there is a line below. The US has a shortage of 19,000 surgeons. Now, look at the number in sub-Saharan Africa. It's 0.53. And again, to complicate things, 87% of these surgeons are in the capital cities.
Mm-hmm. Wow.
This is an inequity within inequity. Mm-hmm. Further, I was really intrigued when you mentioned cancer care was provided by internists. What else is the option? Because the rural part of poor part of Africa is completely neglected. It's completely neglected. That is why the workforce development and the training tomorrow's health workforce is critically important, and training the right professional for the right description.
Super, thank you. It's provocative, I like it. Okay, I'm going to go ahead and open up for questions, either in the room or if Princess sees anything online. Any takers in the room first?
Okay, here we go. So one of the questions we have is, how can universities and community-based organizations co-design academic partnerships that not only train health workers, but also create local economic opportunities and long-term system resilience, especially in contexts bridging both local U.S. communities and international development settings?
Wow.
Easy one.
Tough question. Are we taking more questions?
Oh, yeah. But we can maybe
piece that question.
We can let that one sit for a second. Okay.
Thank you very much to every one of you for this very insightful exchange. I'm a Salata Berke Fellow on Climate and Health, and I would like to ask a little bit, tapping into our last panel as well. In your experience, what are the curricular competencies that matter most right now, given the climate change and the shortage of workforce, not only to navigate the clinical scarcity, which we have been talking about much, but also to grapple with the governance and human rights questions that climate shocks bring into the scene, for example, heat waves and maternal health, or floods and children's health?
Super. Okay, so maybe we'll start with how can universities and CBOs train healthcare workers to create local economic opportunities?
Yes, I think the very first thing governments need to do is define what kind of professional they want. Professionals are not just commentaries workers. They are not just surgeons. They are not internists. It involves everybody. Then do countries in Africa have these mapped out? How many surgeons does Rwanda need today? And then define how do we get there? One of the mechanisms is working with partners, with others. And in my opinion, until that very first step is taken, until we really define what we want, when we want, who we want, it's really going to be difficult. It's really going to be difficult because we don't know what. There's a saying in Africa, Barnabas knows this very well. If you don't know where you're going, all roads will take you there. That's exactly what's happening now. What are we heading? Where are we going? How many surgeons am I trying to produce? When? If that is really clear, then the rest is, I think, technicality. I would start from there. And the partnerships with governments in policy, in development, is really helpful to define this in the very first place.
I'd say one of the things in our California work that we're doing, we're measuring retention of health workers in these rural settings, 2 years out, 5 years out, 10 years out. But there are many organizations, CBOs, government partners that are looking at, is there increased economic growth of the fellows based on their participation in a program like ours. And so for certain actors, economic development of these folks that might be, very low income to start off with, the only income in their family, and does participating in certain programs give them some upskilling and a pathway to grow their own economic development. And so I think there's a lot of conversations happening in California, elsewhere around that, and HEAL's trying to be part of those.
Want to comment?
Yeah, I mean, just going back to your comment a little bit, or even around just geographic distribution, I think the last time there was a survey of just some oncology training touch points, there was around 70 across the continent, but about 3/4 those were clustered in like the north and the south, and then a smattering in the middle a little bit. And so I think back to your point, can you be a little bit more, being able just regionally focused too, to ensure there's even training opportunities that are well distributed in areas where currently those even training opportunities are pretty much non-existent.
Yeah, I think this is where regional collaborations become critically important. At the stage we are in, I don't think all countries will afford to start an oncology residency program. Can we collaborate?
Mm-hmm. Right.
Can two countries collaborate and say, look, our objective is 100 oncology with our 3 countries. You do this, you do this, you do this. What is so difficult about this? I mean, if we need to change, if it's really a challenging time, especially the past 1 year, and we really need to redefine what we are doing, I think we should start from here. And that is why the South-South collaboration, we're working together between countries, becomes really important. And that's why we thought about the consortium of medical schools. Can we look into this? Would this help change what's going on now? Because the path we have taken the past 6 years got us this far, and I don't think we went too far. I would start from the regional collaboration.
Did want to bring up research just for a second, just because, and I hope our welcome colleague is still here, just to say that I do think that research has also a role in increasing healthcare worker capacity, both like in the actual skill level, like We're, training nurses, I remember training nurses to like induce sputa and use a gene expert machine, like 10 years ago, and just the extent to which participation in research strengthens the academic and their questions and the way they think about problems and how they structure their programs to be able to evaluate them effectively, but also other healthcare workers who are working in there. And I just wanted to mention that I think also as an economic driver, getting back to our question, how does this create local economic opportunities? I feel like there are jobs that are created, when you have a surgeon, and then the jobs that support the surgeon, I think is an important part of the economic opportunities.
I was just going to
say something else. Yeah.
Just going to add that we have 2 HEAL alumni in rural India that are running an RCT on AI and community health workers and nurses, trying to see if you get better outcomes compared to some of the physician colleagues, because there's such a health workforce shortage. And I would say that them being from those communities and asking the research question and designing the research study is just much different than if it was designed elsewhere.
Super. Curricular competencies. We have a lot of questions in the room, so quickly, what are the curricular competencies that matter now?
I would go for the non-technical skills, the ability to think, critically think,
yep.
to innovate, to look at a problem, convince yourself, I can fix this, innovate, and come up with a solution. Mm-hmm. The ability to lead and be led. And that conviction, I'm in this world for a purpose. Mm-hmm. To do this as much as I can and then move on. The soft skills, I think, in my opinion, are the technical skills can be learned. Mm. Anyone can learn technical skills, but the non-technical skills are, I think, the most important.
Sure.
I think, we've seen with HEAL alumni a lot of the climate change conversation, just because it's impacting their patients so much. There's migrations or crop failure based on the level of heat in rural Mexico or rural India. So you have a lot of the fellows driving curriculum around how do I connect the dots between what my patients are experiencing and the climate realities. And so I think that's been interesting to see. We have one partner in rural India that because there's been so much crop failure, you've seen people flee to capital cities and get much more high rates of TB. They've started to address kind of organic farming initiatives as a way to address TB in that context. So I think, again, like being proximal to the problem that you're trying to solve, and then building in kind of these competencies that are very much informed from what people are seeing with climate change.
Anything you want to add to that?
I was just going to pivot back to research and thinking about the kind of importance not only for capacity building, but even with oncology therapeutics, we need appropriate representation of the patients who are actually going to get the treatments too. And one of the things that I've been trying to also be really mindful of is, if you are going to be doing something industry sponsored, then what is the downstream access for the patients, right? So if you show something works, then I think really ensuring that there's a conversation, with the kind of health sector to ensure that there's going to be some access framework that is thought of ahead of time in order to ensure that patients, if they are deriving benefit from a therapy, will get access to those therapies as well. So it's, I think, really important, not only just from the biological potential differences of some of these therapies, but I think have to be really mindful of the downstream access of the therapies as well, specifically for interventional trials.
All right, we have a little bit of time left. So can we have a hand? And I think we'll take one last question. Okay, please.
Okay. Abebe, maybe if I will ask you, I think one of the issues we are grappling in the WHO Afro is the issue of migration of health workers. Okay. Therefore, I don't know how would you help us? Try to come with a model in Africa in which we could try to say, because we have frameworks in the WHO, of course, advise later, but the member states actually have a different ideology and actual opinion on this. We're in a free world now. The people are able to apply anywhere. And the government, on the other hand, is saying, no, we have allocated resources to train these people from our own money. As a result, how do you balance that?
I would start from looking at them as humans. Migration, as you said, is a human right. You can't stop people if they are determined to leave. But what if we look at it differently and help them understand they're here in this world for a reason? They're Africans for a reason. Train them well. Train them in that setting. Take time in the rural setting. What HGHI is trying to do. Help them understand your role in this world is to serve this community. Make a change here. Preferential options to those who don't have access. I guess that change might help. But the second, the most important thing is, again, let's not forget they are humans. They have needs. They are young people who want to get married. Probably would like to drive a car. Good school for their kids. They want to grow academically, professionally. Try to provide that. In other words, push factors, I'm sure we know very, very well. It's not because our professionals are being pulled from outside. It's because they are being pushed that they are rather leaving. And there are several publications. It's not money. The commonest pull and push factor is not money. So, again, being pragmatic and if I could also take a few seconds to throw another question. Governments tried to solve this by a strategy called flooding. Some countries said, okay, 100 doctors are trained every year, 50 of them are leaving. Let me train 1,000. This started about 15 years ago. Now, what is the continent facing? Except in 2 countries, the country has excess general practitioners that are unemployed. Have you heard of a GP driving a cab or an Uber in Africa? And we still say the workforce ratio is way below the expectation. So there is something wrong. There is something wrong. Doctors are being produced in excess, quote unquote. The system cannot carry them, cannot pay their salary. There are no hospitals where they can work. And yet there is no access to health care. So something is really, really wrong. Yes. It's only in 2 countries that this doesn't exist.
All right, I think we're at the end of our time together, but please feel free to approach the panelists at lunch.
Now we will break for lunch. Thank you, panelists and our moderator. We'll resume at 2:05, and we'll be here starting the afternoon with a collective reflection, so we encourage you to be on time. Thank you. And I forgot to say you have lunch. Can I have the mic? I forgot to say that lunch is right on the other side of the room. Thank you. We're about to start, so I'll ask everybody to find their seats. Thank you. Welcome back. Also, welcome back to our online audience. I hope everybody enjoyed their lunch. And as promised, we're going to start our afternoon with a moment of collective reflection through the arts. I am very happy to introduce Evan Wong. Evan is a first-year student here at Harvard College and also the 2025-2026 National Youth Poet Laureate of the United States. His work has been recognized and featured by the White House, the Smithsonian Institutions, Google DeepMind, and the United Nations. He has been described quite accurately as a prodigy. He's the first male and Chinese individual to hold this title. He's also a published author. Evan, we're really happy that you're here, so please join me. Thank you.
Good afternoon, everyone. It is such an honor to be here today speaking to a room full of our brightest minds in global health, which, as we have identified earlier, actually does not exist. As a former and failed biology major, I am both intimidated and impressed by you all. I would like to start by thanking those who are responsible for having me here, Carmen, Carissa, Bethany, and everyone else involved. This is a true privilege and a wonderful opportunity for me to get out of class, eat some food, and learn. The National Youth Poet Laureate before me, Stephanie Pacheco, once said that sometimes standing up for something actually means sitting down and listening. Today, that has been my objective. Though I am the National Youth Poet Laureate, my work has never been separated from public health. In high school, I led volunteer efforts for Planned Parenthood and Penn Medicine and hosted creative writing workshops for mental health. Yet, all my life, I've had to close the distance between the arts and medicine. Even now, many Harvard students do not see their intersection. Louise mentioned this morning that me being here showcases, among many other things, who you are caring for, impacting, and striving to protect. I also want to offer that me being here reinforces the truth that health and the arts are wrapped into each other. My best friend of 7 years is a pre-med student in Florida and a huge fan of the memoir When Breath Becomes Air. Written by a Stanford neurosurgeon after discovering his stage 4 lung cancer, one of the most memorable quotes from the memoir is, "Even if I'm dying, until I actually die, I am still living." I am confident that everyone in this room has the brave goal of improving health systems. Many of you have seen their failures, and as such, many of you have seen death. When you come so close to and understand so much of our passing, how could you not appreciate the fragility of our lives? How could you not hold each other tighter? Perhaps that is why so many doctors turn towards music, literature, dance. We share this collective celebration of life. We cry for more life. So I reassert, global health is poetry in practice. So before we jump into our poetry reading, I have something I would like to do that I typically like to do before poetry readings, and that's to take deep breaths. I learned this from my therapist. It's box breathing. So let's breathe in for 4, hold for 4, and breathe out for 4. Okay, we're ready for poetry. I will not be reading a poem that is by me today. I will be reading a poem by Seamus Haney, who is a former professor at Harvard. This was written in 1985 at the request of Mary Lawler, then head of Amnesty International in Ireland. Valuing humanity over bureaucracy, this poem reveals a vision for a kinder, more connected world. From the Republic of Conscience by Seamus Haney. 1. When I landed in the Republic of Conscience, it was so noiseless when the engines stopped. I could hear a curlew high above the runway. At immigration, the clerk was an old man who produced a wallet from his homespun coat and showed me a photograph of my grandfather. The woman in customs asked me to declare the words of our traditional curses and charms to heal dumbness and avert the evil eye. No porters, no interpreters, no taxi. You carried your own burden, and very soon, your symptoms of creeping privilege disappeared. 2. Fog is a dreaded omen there, but lightning smells universal good, and parents hang swaddled infants in trees during thunderstorms. Salt is their precious mineral. And seashells are held to the ear during births and funerals. The base of all inks and pigments is seawater. Their sacred symbol is a stylized boat. The sail is an ear, the mast a sloping pen, the hole a mouth shape, the keel an open eye. At their inauguration, public leaders must swear to uphold unwritten law and weep to atone for their presumption to hold office, and to affirm their faith that all life sprang from salt and tears, which the sky god wept after he dreamt his solitude was endless. 3. I came back from that frugal republic with my 2 arms the one length, the customs woman having insisted my allowance was myself. The old man rose and gazed into my face and said that was official recognition, that I was now a dual citizen. He therefore desired me when I got home to consider myself a representative and to speak on their behalf in my own tongue. Their embassies, he said, were everywhere, but operated independently, and no ambassador would ever be relieved. Thank you.
Thank you, Evan, for such a great and powerful performance, but also for the words that you had about our sector, and I think it's quite right. And I'm very happy to now introduce our last plenary session of the day. We're closing this day with a session being hosted in partnership with the Petrie Flum Center for Health Law, Policy, Biotechnology, and Bioethics at Harvard Law School, as well as the David Rockefeller Center for Latin American Studies here at Harvard. To open the conversation, I'm delighted to welcome Sol Carbonell. Ms. Carbonell is the Executive Director of the David Rockefeller Center for Latin American Studies, and she has been a vital force in bridging these regional conversations across the university and beyond. Sol, we're honored to have you here, so please join me in the podium. Thank you.
Thank you for that kind introduction and for the invitation to co-sponsor this amazing panel with you. And in the meantime, if I could please have Alicia and the panelists come join while I say just a few words. It's really an honor for me to help transition the conversation to another part of the world, to Latin America, where our center is focused on. The David Rockefeller Center for Latin American Studies is referred to as doctor class. So if you haven't heard that before, it is incredibly confusing for the students when they get to campus and they are referred to see the doctor for all their interest in Latin America. But that aside, for the last 30 years, our center has focused on 4 primary pillars. First, we fund and facilitate faculty and student research in the region. Second, we create transformative student experiences in the region as well and on campus. Third, we host visiting scholars and fellows from all disciplines to come spend some time advancing the research here at Harvard. And last but not least, we promote public debate and conversations like the ones we are about to have today. For more than 15 years, we have also supported the field courses that the School of Public Health does in Brazil, in Chile, and Mexico. Last year, just to give you a quick example, through our internships, in Mexico City, we hosted students at the National Institute of Public Health, an institute focused on cardiology, and on another one doing research on pediatrics. And those are amazing opportunities for students. And through our Lehman Brazil Research Fund, we have also been able to support research on a range of issues, from infectious diseases to vaccine rollout, to community health interventions, to name a few. And before I introduce our distinguished moderators and wonderful panelists, let me just offer 6 themes of the kinds of conversations that we've been having at the center just this month. And I'm not going to go into any of the details here, and just to set the stage. Number 1, increased polarization and far-right movements that have made it into power in Latin America. Number 2, shift away from multilateral organizations, diplomacy, and international cooperation, and move towards militarization and reorganization of international alliances. Number 3, increased misinformation, media segmentation, and echo chambers that reproduce biases. Number 4, low state capacity, not state size, but state capacity to provide effective and efficient services, including the provision of healthcare. Number 5, erosion of trust in institutions and strong public discontent. And obviously, number 6, the emergence of AI, which has a tremendous capacity to, of course, improve productivity and increase efficiency, while at the same time produce a vast amount of misinformation and demands an enormous amount of water use in a time where already access to quality and consistent water in Latin America is a real problem. So I wouldn't be surprised if some of these themes actually emerge in the conversation today. Personally, this topic is incredibly important to me, and is not abstract, because I am, as perhaps some people in the audience or those that are watching over Zoom, and one of those that has a personal experience of having to use the court system in Argentina through an amparo to be able to secure guaranteed pain medication during the last few months of my own mother's battle with pancreatic cancer. So personally, I want to thank you for your tremendous commitment to improve the healthcare system in our region, and for your fierce determination to advance public debate on this. And with that, let me introduce our esteemed panelists and moderators. And I'm hoping that throughout the conversation, you can also give us some insight into the creativity, the innovation, and the resiliency that we see in our region every day. So with that, let me tell you who we have here today. We have Claudia Peseto, who is the Regional Advisor of Evidence and Information for Health Economics and Finance at the Pan American Health Organization and WHO. We have Dr. Alejandro Gaviria, who is the former health minister, the Minister of Health and Social Protection and former Minister of National Education of Colombia, and Dr. Victor Zamora, who is the former Minister of Health of Peru and Professor of Health Policy at the School of Government and Public Policy at the Pontificia Universidad Católica del Perú, and Executive Director of the Gobierna Consultores. And our esteemed moderator is Dr. Alicia Yamin, who has joined appointments at the Harvard Law School and the School of Public Health, and teaches on health policy and management, and is a senior fellow on global health rights at the Pietro Flom Center. So Alicia, thank you so much, and welcome to all of you. Take it away.
Thank you so much. Thank you so much, Sol. And I hope we can touch on both some of the challenges that you laid out, as well as the innovations, which are both technological and also social, I think we'll highlight. Because it's been a long day, and this is the first panel that we are having on Latin America. Some of this is going to be sort of explaining the very different sets of challenges and realities that Latin America faces. I want to start out by saying that it is an incredibly diverse region, diverse politically and economically and socially, but also in terms of the stages of epidemiologic transition that it's at. So there are challenges with NCDs, but there are still also very profound challenges with infectious diseases in areas of the region. And I don't want to erase or flatten that diversity when we talk about commonalities. It is a region that, in general, faces very steep socioeconomic inequalities and social fragmentation along gendered, racial, ethnic lines, rural, urban. And those differences and disparities show up in health outcomes, for sure, and are reflected quite acutely. It's a region of paradoxes with respect to health in many ways. There are lots of historically health justice movements from immigrants that came from Europe and were hoping to set up the same kind of universal healthcare systems that were in Europe, and worked for social security systems and health in Latin America, to indigenous movements from Lázaro Cárdenas to the Zapatistas in Mexico, to a special brand of Latin American social medicine, the Brazilian sanitary reform movement that was absolutely critical in the transition from the Brazilian dictatorship into democracy and embedding principles in the Constitution, to the Green Wave for Reproductive Justice more recently that started in Argentina and swept across Mexico and Colombia and elsewhere. But on the other hand, it's also a region where the immigrants did not achieve universal health care in most places. There are segmented health systems. And it's very highly medicalized, despite the Latin American social medicine. There is, as Sol mentioned, quite deep polarization and fragmentation in politics across many of these countries, as well as what, as a lawyer, I would describe as pretty profound regulatory and compliance gaps with respect to health as well as other areas. There's health systems around the region often stratify citizenship in a region which is already struggling with political inclusion. And yet, at the same time, I hope we'll also be able to highlight some of the great innovations and initiatives that have been taken, including by people on this panel. So with that, setting the scene, I think I'm going to turn to Claudia first and say, you know, you have spent your career tracking financial health and stewardship of the health systems across the region. Could you give us a sense from your perspective, having worked at Bajo, of 2 or 3 of the major challenges?
Thank you so much, Alicia. And I would add to your introduction that also Latin America and the Caribbean is a region with great ambitions, great achievements, but also with great challenges. And this leads me to try to answer your question. And I will say that the first issue that we'd like to highlight is that one of the main challenges is the big segmentation that exists in terms of financing. And this was rooted in the uprising of the social health insurance movement back in the 60s that segmented the systems and segmented the population, and also the access and the entitlements of different population in terms of who has access. If you are an employee, of course, you have access to a set of benefits, and you go under, and you can run under some rules of coverage as well. But it happened that model, that it sounds appropriate, didn't take into account the high levels of informality, for example, that persist in the region and have been developing and have been even deepening with the years after all the different economic cycles and challenges that have been faced. So segmentation it means that we have, along with the public sector, we have another share of the public sector that responds to a very specific group of the population, and that creates a lot of distortions in terms of inequalities to access, and also on the quality of the services that people have access to. Fragmentation is also mirroring this situation in fragmentation of the health services themselves, how health services are organized, that correspond to this segmentation somehow. We had these social health insurance models focus more, for example, on specialized care, whereas primary care, which is mostly concerned on prevention and promotion, has been derived to the public sector themselves. That's one of the issues. The second one is, and that it stands out in the region, is the lack or insufficient public investment in health. And as we are ambitious in the region, we also set very ambitious goals. For example, in 2014, the countries or member states approved a resolution in PAHO to increase public health investment to levels of 6% of the GDP at least. Well, this hasn't happened, of course, in 2023. And after a spike during the pandemic, but in 2023, the levels of public health investment are around 3.8% of the GDP, which bring us back to the levels of 2019. There are variances in between. There are 4 countries that have, 3 countries in 2023 that have only achieved this goal, Argentina, Cuba, and Uruguay. At some moment, there were even 6 or 7. And along with this, the reflection of this lack of investment is the increase on out-of-pocket payments. There is a clear correlation between public investment in health and out-of-pocket payments, because if the public sector doesn't have the capacity to offer or to meet the demands of the population, obviously the demand and the needs are there, and they somehow need to be attended, right? They need to be met, and people tend to have no other option than going to the private sector. That's what generates out-of-pocket spending that has been increasing slowly during the last 2 or 3 years post the pandemic. The third factor, and I'm gonna stop that, but I think it is important because of the discussion related to governance, is that in Latin America we have this variety of centralized and decentralized states. So this segmentation also in terms of how the health financing system is organized in terms of entitlements, social health insurance, etc., has also another bucket of segmentation that is related on how the public funds are generated, are allocated, and are used. Because in those countries where the regions have or are decentralized, or the central power is decentralized to the regions or to municipalities, it also creates even more dysfunctions that at the end of the day impact on how the public funds have results or have a real impact on outcomes in health.
Great, that was a super helpful overview. Alejandro, can I turn to you, because Colombia in many ways has experimented with and achieved quite a lot in terms of addressing segmentation, out-of-pocket costs, and other issues related to financing. So could you talk to us about what Colombia has done and how it did that?
Okay. Let me say first that Latin America has been called the forgotten continent. And we share some of the problems of the African continent that we discussed this morning, but we also share some of the problems of the global north that also we mentioned today. And Colombia, in a way, summarizes that. If I have to pick a headline to explain what happened in Colombia over the last 3 decades, I will pick the cost of success. Is a contradictory, paradoxical, even tragic story. It's a story of social progress and a story of paralysis that we are seeing now. In the early 90s, Colombia was in a very difficult situation. The Colombian democracy and the Colombian institution, the Colombian society was threatened by terror and violence. And Colombia, my country, responded to that with more democracy, with a new constitution in 1991. And with this constitution, we have a wave of reforms, the fiscal reform, the centralization or decentralization reform, and social security. And we created an ambitious health system based, Alicia, on one idea: solidarity in the finance and equality in the benefits. And we achieved quite a lot indeed. We reduced out-of-pocket to 15%, out-of-pocket payment, 50% of total health expenditure. That is the same level of a typical OECD European country. In Latin America, the average is over 30%. For some diseases, say chronic renal disease, Colombia now has 40,000 patients, and they receive very good quality, specialized care, zero copayment. The reform invited the private sector. We have private providers and private insurance companies cooperating with the Colombian state, and that was controversial from the beginning. But that created many capacities, social capabilities. And also the reform mandated a substantial increase in the budget. But now we have strains, we have problems. And the first one is the financial problem, the financial sustainability, and we'll talk about this a little bit later on. But now the deficit of the Colombian system is about 1% of GDP, of the Colombian GDP. So it's a huge one, and it's increasing. And also for the last 3 years, the health reform in Colombia has become a battlefield of an ideological war. And the health system is deteriorating rapidly. And we know that health systems don't go bankrupt. They adjust against the people. People are suffering. And this, Alicia, is sad. And the country is destroying some of the capabilities that we built with much effort over the last 3 decades. That's the situation now.
So, Victor, can we turn to you? Because I don't think the slogan for Peru would be the cost of success.
No, it is not.
So maybe you can walk us through a very different scenario in Peru with a lot of political turbulence and a lot of fragmentation.
Well, thank you very much for the invitation. And I would like to build up on what Claudia has mentioned. She has mentioned fragmentation, segmentation, decentralization as 3 facets of characteristics of our health systems in Latin America, which we have in Peru as well. But I would like to mention 3 different ones, which I think are relevant. One of them is chronic underfunding, especially for Peru. 3.5% of the GDP, which is the GDP of Peru. You know, it's a very poor country in terms of investing on health. The second aspect is corruption. Corruption undermines the health system in general. But it's not proper to the health system, but also for the entire society in Peru. And finally, I would say during the decapitalization of human resources doing the managerial work, And that's a result of what you have mentioned, fragmentation. But fragmentation is, second, is not an aspect that we have to take into account only for the health sector, because it's deeply rooted in the history of Latin America. It's a result of clientelism and paternalism in their relation with the state. Those who have the power, those who live closer, they will have their own health system. And finally, fragmentation is also it's an attempt. I mean, I am surrounded, as in the ministerial cabinet, by a lawyer and two economists, and they look, especially the economists, from the efficiency perspective. You cannot be fragmented because the costs of transactions is very high. You can get more out of, which is true, more out of the same money. But looking from the human rights perspective, fragmentation is a threat, because the constitution in Peru establishes that we are equal, and we are equal according to the equal. Every Peruvian is equal. How would you say equal in the law? And secondly, that we have the right to health. But since we are living in a fragmented world, our rights are also fragmented. Our citizenship is fragmented from the human rights and health perspective. We are not equal in terms of health care, health access, health benefits. So from the human rights perspective, fragmentation is a major threat, and we have to deal with it. Let me just put some figures to get you closer to the Peruvian reality. We have six systems, national systems. First, the Ministry of Health system, which is financed by taxes. The Social Security system, which is financed by those who are employed. Those who are employed are about 30% of the entire population, and the rest, 70%, is informal or not have a job at all, very poor people. Then you have the Ministry of the Public Financing, the health system for the army forces, which are three: naval, Air Force, and And then you have the health system for the police forces, and then you have the health system for the judiciary system, which is take responsibility for the healthcare of the prisoners, and then you have the private sector. You have to multiply those by 25 regions, and you have 4 or 5 funds. You can cross those lines, and you can imagine how difficult it is to manage that system in general, how difficult it is for a person to navigate in such a difficult environment. It's paradoxically, we have our big brother Colombia, which has taught us a lot during these years. Paradoxically, during the last 15, 20 years, we have moved from 50 to 60% of people who have an insurance to 97% or 98% of the people living in Peru that formally have an insurance, a health insurance, including our visitors from Venezuela. They are included in the health insurance. But one thing is to legally have an insurance, but a very different story is to have healthcare, in the system, because it depends on what type of insurance you have, what type of healthcare you get. Being the Ministry of Health, the most the most fragile system in terms of delivering care for those entitled to. So if you have fragmentation and the capacities of the government to implement a health insurance, what is the response? Fragmentation is a major threat to the right to health in Peru. fragmentation. It's not an efficiency aspect. It's a human rights perspective, and we have to look after.
I agree. So I actually want to follow up with you on some of the things that you brought out because, you know, as I think Sol mentioned and I mentioned and a number of us have mentioned political polarization. And health really is deeply political, even if we fool ourselves into thinking that it's just a technocratic undertaking. And that could not be more clear in Latin America. You in Peru, I mean, there have been 10 health ministers in the last decade. We are right now today going through sort of the last election is kind of finishing up. We don't know exactly who the president is going to be, but we have an idea. So I wonder if you could talk about being Minister of Health, and you were Minister of Health when the COVID pandemic began, and how the politics influences your ability to carry out your agenda.
Well, health is political. Health reform is political. Being Minister of Health is a political task. But in Peru, you know, you are not counting well. During the last 18 ministers of health since 2015. Since 2015, we have had 18 ministers of health. And during the pandemic, we had 5 ministers of health.
During the pandemic?
During the pandemic. 5 ministers of health,
oh my God.
3 presidents, 2 Congress, 1 election, and a huge protest during the pandemic. So you can imagine how political is the scenario. Well, that's an extreme situation, I would say. Having said that, considering health as a political issue should not be, on the contrary, consider that health should be politicized. Politicized in the way these organizations, all of the I have mentioned already, is being used for clientelistic purposes, you know, corruption or whatsoever. Politics is damaging the health reform or any modernization of the health sector in Peru, because politics is not transformed into institutions. So everything is short-term. We cannot think in long-term perspective. We have lost the long-term vision of what we want to achieve in Peru. We have made some efforts. Health insurance, the national public health insurance, has been created and developed and still maintained, even when everything has changed. 18 ministers and the health insurance still running and increasing little by little. We have to look after these kind of successes in the middle of the chaos. You know, we have reduced undernourishment from 30% to almost 10%. We have increased health facilities for mental care at the community level. Something is happening in between. In that chaotic environment, there are some things that are happening, and we can show to our neighbors, to the world. But I think that eventually, if the situation calms down, we can do much better than what we have done now.
So Alejandro, the situation in Colombia when you were Minister of Health, and you were Minister of Health for the entire period of Santos?
For half of the first period and the entire second period.
And for the entire second period.
6 years. I've been the longest serving Minister of Health in the history of Colombia, for better or for worse.
But you were also Minister of Health at a very interesting time, because not when a judgment, in Latin America, there are many countries, including Colombia, where the right to health is a constitutional right. And there had been an increase in judicialization of the right to health, so that there had been 700,000 tutelas or protection writs by about 2008. And the Constitutional Court issued a major structural judgment that called for the restructuring of the health system. And thereafter, you became Minister of Health, and we're dealing with a lot of different political forces at the time. And you know, how was that to navigate that?
I'm going to tell you that, but let me first say something strange about this thing is political. When I was appointed Minister of Health, I was an academic. I was the Dean of the School of Economics of the University of Andes in Bogota. And one day the president called me, and he asked me, "Do you like challenges?" And I say, "No."
Was suspicious, right?
And I finally accepted, but was not a political appointment. And the reason for that was political economy. The system in Colombia is complicated that he didn't understand anything. And he basically told me, "Take care of that." And I realized pretty soon into the game that I have a lot of leeway to make decisions, but he was supporting me. And that's why I was minister for so many years. And one of the problems was the sentence, the judgment, how do you call it, the
Judgment, sentencia, judgment.
Sentencia, yeah.
T-76008.
Colombia is a country of lawyers, and we have this thing that we memorize the numbers of the judgments and the numbers of laws. So everybody in Colombia familiar with the system know the T-760. T-760, that's the judgment. And I read 500 pages of the judgment without a spelling mistake. Perfectly written, but problematic. That sentence, Alicia, that judgment, didn't have a reflection about the ethical consequences of creating a very open system with everything, every technology, every new medicine was in theory included. Didn't have a philosophical reflection about this tension between a utilitarian sort of view of health and the Kantian or deontological view. Everything was included. Rule out that judgment, rule out any form of priority setting. So I have to deal with that. And I decided to fill that void. So the Constitutional Court had decided not to give that debate. And I decided to create a space for that conversation. Our life is complicated. In June of 2017, I was diagnosed with cancer. And I had this ironic coincidence of being Minister of Health and cancer patient. And you know what? I took advantage of that opportunity to put into the discussion these bioethical dilemmas. And I wrote a letter to the public saying, I'm going to be treated in Colombia with the same basket of benefits of any citizen. And that created a debate. And that changed the situation a little bit, and we have had since then interesting and difficult discussion.
So I have often thought, I'm going off script here, but the justice who wrote that opinion,
Manuel José
Cepeda, left the court within 6 months. And at that time, you were not Minister of Health, but then shortly thereafter, you were. And we, you know, in academia like to talk about different structural forces, et cetera. But after really studying this judgment and the after effects for many years, I often have thought that if you two were in your positions at the same time for enough years, that things would have turned out very, very differently.
he taught me something very powerful, a sentence. He taught me, we have to be able in Colombia within the society to collectively construct a no, how to say no in a health system in a legitimate way. And we still don't know.
So Claudia, can I turn to you with your regional knowledge? And you know, there is a lot of political turbulence. Every time a new government takes office, priorities may shift in terms of health. Sometimes advances are paused. Sometimes there is an entire reversal. So, you know, after your long career and decades of working with different governments, how do you manage that? How do you manage?
I'm not that old, Alicia.
No, go on. As my decade.
It's okay. But first of all, before I answer your question, I want to tell Alejandro that we as economists are supposed to be the worst ministers of health ever, because we always start saying, any discussion, saying that resources are scarce. And a medical doctor and public health people, medical doctors say, well, I have to save lives. It doesn't matter how much does it cost. And public health people, well, we have to meet needs of the population. So there's a conflict there, and you are not the only one on the back. And from the regional experience, one of the most successful reforms that happened in the region has been the one in Uruguay, and surprise, surprise, it was led by an economist, while a Minister of Health was an economist, Daniel Olesker. And, but anyhow, and just to answer your question, Alicia, and piggyback also on the example on Uruguay. Uruguay also has the same problem of judicialization as Colombia has, as Argentina has, as Chile has, Brazil as well. And in Uruguay, it has arrived to the level that it has been very relevant. Because, for example, last year, the amount that was paid through judicialization causes was equal to 51% of the budget of the Ministry of Public Health. So this means that it's being spent more on that than on the regular operation of the Ministry of Health. How this has been, and I'm putting Uruguay as an example because I think it is one of the health systems more successful in the region, together with Costa Rica. This might be very debatable, and some other country might say, no, my health system is also successful. But I think in terms of sustainability and the achievements and health outcomes, I think Uruguay is a good example. I just lost what I was going to say. But it's not the only place. The way that they were able to deal with this amount of utilization has been to opening the floor. I mean, bringing all the actors together, and I think this is the recipe that might be successful. You have to open the discussion, because priority setting in a context where the right to health is ingrained in the Constitution, it requires also that the social contract gets involved, right? And that everybody needs to have a say on that. And that's not easy. That requires leadership. It requires experience. It requires openness, to listen and to come up with a solution that is going to be for the benefit of the society. Because in every negotiation, there's always losers and winners. The trick is to make the losers think that they are not losing that much, that they are winning a little bit, even though they are losing. And I think Uruguay has been very good in doing that, and I think this should be the way to do it. Bring in the academia, bring in the people in charge of the technologies evaluation. I mean, those that tell or that say decide which medicines, for example, are going to be guaranteed or are going to be part of the package of benefits or not, or also people from the constituencies, right? People from the Congress, specialists, economists, everyone together, even the private sector, because most of the causes of judicialization are related to either high-cost treatment or high-cost medicines. I mean, high-cost treatment is related to high-cost medicine. So the industry also has a say on that. And I think it is the way to go out. It's inevitable, at least in our region, that we are going to have this swinging between different visions on how a country should go. We have more left-sided, let's say, although it's kind of relative now, but more to the right, more to the left, or to the center. That's inevitable. But the vision of the country, at least there must be some consensus. And that goes through a strong social contract that is built up on the basis of dialogue. I think that would be my answer.
Okay, I'm actually going to go to you about T760 in a sec. Can I just set you up? So I will say, we all have different perspectives on this phenomenon of judicialization. I'm a lawyer, and I've worked on it from one perspective. I was appointed by the Colombian Constitutional Court, and I've worked on it in Argentina and elsewhere. I think judicialization should be understood more as a symptom of problems than as a cause of problems, and a symptom of many of the things that have been mentioned. The fragmentation of the system that makes the setting of cost-benefit thresholds impossible across the board. The regulatory and compliance gaps that allow for enormous gray areas, the lack of priority setting, the lack of pharmaceutical regulation, which actually I'm going to come to you now, Alejandro, because you were very active in addressing that. But I wouldn't want us to walk away thinking that the judicialization of health rights has been unequivocally bad. The T760 decision itself was a response to individual litigation that had become just unmanageable. And it was a dialogical judgment. So it didn't say the right to health means X, Y, Z. It deliberately threw it back on you in the Ministry of Health and Social Protection to say you need to adjust the contributory regime and the subsidized regime, fix the reimbursement schemes, and a whole lot of other things. So I'd love to hear your perspective of having gone through that period.
Alicia, I think judicialization is both. Is a symptom that this fragmentation and problems of the system, but also is technological pressure, is the new innovations and so on. If you look in Colombia, the geography of judicialization, you're going to find something that is paradoxical. It's in the main cities and in upper middle classes where you find more cases of judicialization. That is...
They can pay the lawyers.
Yeah.
Tells you something.
A lot.
Let me tell you another anecdote. I have almost every other month a conversation with the leader of a pharmaceutical company in Colombia. And we are together for lunch. And I always ask the same question. Where have you been? And he or she tells me in Brazil, in Peru, in Mexico, in Colombia. What do you think of the Colombian system? Oh, it's the best. And I'm worried because this very open system has been very good for the pharmaceutical companies. And the technological pressure is probably the main cause of the fiscal and financial problems that I described. Let me go back to the numbers of judgments and laws. So we have T760. And after T760, the judgment, came a law, and a statutory law. It's 1751. So in Colombia, everybody knows the T760, and everybody knows the 1751. And the 1751 was a way to incorporate some of the mandates of T760 into the law. And we created some exclusions. And I spent almost a year in Congress trying to do some educational sort of work, telling to senators and representatives about these topics. And the Colombian Congress made this decision, say, no reasons of cost benefit can be argued to exclude a technology, medicine, or anything. Only what is experimental, but doesn't have any evidence, can be excluded. And that's complicated. Especially in modern medicine, where you have this tension between value and price. So it's impossible in Colombia now to say, no, you have this new cancer medicine. It's associated with 1.1 months of overall survival and cost 3,000, 4,000, 10,000 per month. You cannot say, for reasons of price, that's going to be excluded. And that's complicated. And
I agree with that. Right.
I have continued participating in the public debates about health reform in Colombia. And every week, I get a message in social media. Somebody telling me, you were minister for 6 years. Why you don't solve these problems? Why you didn't solve these problems? And my only honest answer is they don't have a solution. You have to manage them. You have to do a lot of stuff, and I'm going to describe in my next intervention what we did, just to maintain this precarious position.
Well, Victor, Peru is a very different scenario.
It is.
There is not the same kind of judicialization at all. So we'd love to hear your perspective from, a ministry in a country where that is not so much of an issue.
Well, I would like to warn the audience that not having a judicialization process should be understood as a romantic place where there is no problem. There are no problems. On the contrary, silence speaks a lot. Why we don't have a judicialization process in the size or with the impact that Colombia has had? I think one of the reasons is that to navigate the judiciary system in Peru is quite difficult for any person. It's very costly. So very few can afford to navigate in the judiciary system. Secondly, it has to do with citizenship, quality of citizenship. I don't know if you have met Sinesio Lopez, who is a sociologist who has written a book about the types of citizenships that are in Peru. He mentioned you have high citizenship and low level of citizenship. When you know your rights and you can exert your rights, it's high level of citizenship. When you don't know your rights and you do not exert your rights, you have low level of citizenship. So you can imagine the majority of Peruvians do not know their rights, and they do not know how to exert their rights, and they don't have the means to exert the right. So it means low levels of cases will reach the judiciary system. Thirdly, what you can achieve. What you can achieve in terms of it's case by case. It's not those who reach the judiciary system and eventually have reached a positive result. It's just case by case. It's not it is not transformed into a policy or a law. It is just case by case. Eventually for HIV patients, but that's not the norm. The norm is case by case. It's costly. It's not in the rural areas, so the judiciary system is far away from the regular Peruvian citizen. Fourthly, there are some other mechanisms that have been developed, parallel mechanisms. Within the Ministry of Health, for example, the Superintendency of the Health, it has been created on the purpose of protecting the rights of the people using the health system. But since it is appointed by the Minister of Health, the superintendency does not exert they do not fulfill their role as correcting the errors in the system, because it's politically appointed by the Minister of Health. So there are problems there. And finally, during my tenure, I have created a Center for Health Technology Evaluation in the National Institute of Health in order to have a clear path, a very transparent one, to choose which technologies can be supported by the system. Those two are very weak. They are on its infancy. But I think if the judiciary system is not the right tool to use, we can develop some others in order to fulfill the right to health for the Peruvians.
So perhaps I should just explain for those of you who aren't familiar with Latin American laws. So many of these, when we say how many lawsuits there have been, the protection writ is extremely easy to use. So in many countries, including Colombia, you don't need to even have a lawyer. So for people in the United States, it might be more akin to saying, a complaint with your pharmacy benefit manager, right? It's not the way we think of litigation in this country, and that's why the numbers can seem astronomical. Right, so the legal opportunity structures are very, very different. That is not the case in Peru, and that explains quite a lot of the difference. But in Argentina, in Brazil, in Colombia for sure, and to some extent in Mexico, and in Costa Rica, in Uruguay, in Chile, to some extent that is the case. So we are now moving into the last segment before we open to questions, and it's really sort of about regional governance. We now are moving into a new kind of multi-level multilateralism. Latin America is not by any measure, stretch of the imagination, aid dependent in the same way that some of the other countries and the region of sub-Saharan Africa is. So, but in Latin America and in the Americas, the US and Argentina famously have pulled out of the World Health Organization. So I guess I would turn to you, Claudia, to say, what is the role of Bajo in this new world order?
The brave new world.
Well, I don't think the role has changed. It just has evolved, but it hasn't changed. It's in the mandates. It's in the constitution of Bajo, which is previous to WHO. We love to say that. I know Calypso is still here. We love to say that we are older than you. But anyhow. But I just would like to focus on what we have been doing from the Health Systems and Services Department, where we have been which I belong to. And I think the idea has been, in this era of less resources, less financial resources, we're trying to emphasize the way of how to strengthen experience sharing and put countries together on one side, creating different networks on the essential public health functions, on how to better manage health services through integrated health services networks, through a group of national health funds and where they function in the region. So trying to find ways and scenarios where the experience sharing can be strengthened, and where the good lessons could also be drawn from, right? And in the other hand, what we have been trying to do is to promote, and in order to respond to the lack of public investment, we are conscious that the macroeconomic and macrofiscal outcome in the region is not too promising, right? So we need to try to create or enforce the consciousness that the few resources that we do have is what we are going to have to work with, while we still do advocacy for increasing fiscal space in many ways, but also the need to better use the scarce resources that we have, and to how to improve efficiencies. And there are still many ways to do it. We are also working hard with the development banks, with the Inter-American Development Bank, and also with the World Bank through an alliance for primary health care, where the idea is trying to put our forces together to avoid duplications, those duplications that were mentioned earlier in the morning session, for example. Those also exist in the region, and at the country level, they can become very complex, because you have different funders sometimes trying to work on the same topic, and with different checks and balances for each of those funding sources, so it becomes very inefficient. So the idea of the alliance, for example, is trying to put them all together, sit them all on the table with the ministries of health, sitting, when I'm saying all, I'm talking about the World Bank, the IDB, and PAHO. PAHO doesn't fund, but we provide technical advice with the ministries of health, and trying to come up and to coordinate the agenda to make a better use of the resources. So I think that's the best way that we are, the way that we are trying to strengthen now. And I think we're being quite successful. We have some countries that are adhering to the alliance. I think so far it's six or seven countries already, and they are working on more. And we hope that this is going to be effective, and that the changes of government will not affect this compromises, right? And or commitments. I'm sorry. And it's a way to ensure sustainability of what we do, as it is also created evidence. Something that we lack in the region is that we have great policies, we have great regulations, but we don't have the evidence of what works or what doesn't work. And I think that is important, because that's the way that you can guarantee impact, and ultimately you can guarantee sustainability, right, in the long term. And it might be a way also to shield some policies, right, and to shield them from these swings that we were talking about earlier. Because if things work, there's no way to dismantle them, right? At least in theory. We have seen weird things lately, but it's a way to ensure sustainability of the things that really work. And I think one of the big challenges of health systems is that they are evolving. Nothing is static, right? Everything changes. The epidemiologic profile is changing. The demographic profile is changing. The pandemic gave us big lessons that, as Sonia, she portrayed it very well. She described very well. Now everybody is suffering of collective amnesia about what was learned from that, right? Nobody wants to talk about it. And I think there were very good things that were done in that. And we have taken the way to highlight some of the things, the well things that were done. For example, digital health, now artificial intelligence, and so on, which are very useful. But there are also some other things at the root that need to be fixed in order for those advances to work well. For example, the quality of the data. It is important. We can have interoperative information systems, but if the quality of the data is not good, we're going to end up with any result. So there are many things at the basis that still need to, we're trying to leapfrog from paper doing to artificial intelligence without, and that's my concern, without having fixed in the middle, right, in the inputs. So we'll see what happens in the following years. But I mean, we are, at PAHO, we have the advantage that we are present in almost every country in Latin America and the Caribbean. We have offices in most of the countries. In Latin America, for sure. In the Caribbean, we have some regionals, etc. But and I think that's the best way to ensure that things, because. And this is not like a propaganda or merchandise. I'm just trying to explain the value that PAHO has in terms of the continuity of the value of the what the things that have been achieved, right? Even though the government officials change or the orientation or vision of a determined government changes. So, yeah.
That's right. So Alejandro, can I turn to you? You said you had told these people that there was no, you hadn't found the solution because there was no solution. But looking ahead, what would be your priorities for the Colombian health system, and what are some of the possible risks or challenges facing Colombia now? You have an election coming up?
Yes, we have an election May 31st, presidential election. I met last week with the president of the Constitutional Court, and we had a very interesting conversation about everything. And I saw, Alicia, that probably there is convergence. A consensus is emerging in Colombia, for example, about the importance of priority setting. And the civil society, Physicians Association, the academia, Constitutional Court are working together despite political polarization. And this is good. And I don't know if I have been a little bit like cynic, but I believe in that we need a bias for hope. I want to call it that way. That we are not going to solve all the problems at once, but public policy can make a difference. And as I mentioned, I regulated prices. I did something crazy. We did a compulsory license for medicine for reasons of price. And I don't recommend it. It was a tremendous battle. But we advanced.
And he got a lot of pushback from certain people in the United States.
I got a letter from Joe Biden. He was then Vice President of the United States, saying that if we continue with this, they are going to suspend the help for the peace process at that time. Mm-hmm. I don't know why I wasn't fired, but something happened. I think it's also important to say that if we see convergence of health outcomes, the story of Latin America has been impressive. And I want to be a evidence-based optimism. There are many things that we can do. And yeah, political polarization is an obstacle, but we are still working together. And I was for some years also president of a university, and almost every day I used to say the same: we have to connect more with civil society, with government, and working together. And this is what we're going to do. Yeah.
Can I just add one thing?
Change the world. Yeah.
This is not a promo for Alejandro, but we haven't talked a lot about social determinants. And one very important measure that he took as Minister of Health was to ban glyphosate. Now, glyphosate in Colombia is obviously hugely important to the drug war. So there was a lot of blowback on that, too. And I think it took enormous courage and integrity. Maybe you just want to say a word about that, too?
Yes. Glyphosate was used for spraying coca fields. And we started accumulating evidence that this was related to all type of health problems. And one day, I went to see the president. And I told him, look, the evidence we have, including everything is connected. Some evidence of the effect of glyphosate in non-Hodgkin lymphoma, the one I got. I was not sick then. This is how life connect with many things. And the president told me, I want to make that decision. And we made that decision. I didn't ask anything. And was a huge battle inside the government. And since then, glyphosate is not used as the anti-drug policy in Colombia, and that was a victory for many communities in the periphery of the country.
Okay, so turning to you, Victor, what are the hopeful kinds of signs of innovation in Peru and possible also challenges that you see coming down the pike? You've just had an election. It's also a complicated political scenario.
Well, we have to close the gap. We have a lot of debts in social terms. That's one of the main challenges. We still have tuberculosis. We still have plenty of people living in zones affected by malaria, dengue, and some others. Another challenge dealing with the new epidemiological profile and demographic profile. We have challenges including in our health system, new technologies, and financial challenges, as everybody. So the challenges are there. But we are not going to be successful dealing with those challenges if we do not take into account the lessons learned during the pandemic. And I will share with you 4 of my own reflections. Being a very weak health system, you can see the figures everywhere about how the performance of the Peruvian society during the pandemic. And I think it summarizes in 4 lessons. First one, and this is something that PAHO, IDB, and some others will have to take into account, especially in these times. First, we need more state, stronger state. It doesn't mean a larger state. It means a responsive one, a state that is present where now is absent, totally absent. And it calls for more money, more people, and a lot of things that we have to discuss in terms of the presence of the real presence and effective presence of the state. Secondly, we need more evidence. As mentioned here, a very beautiful story. The evidence should be highlighted as a main tool for decision-making process. Even though we have a political turmoil around us, evidence should play a key role in the decision-making process. Thirdly, more ethics is needed for public policy. Ethics is very key. I'm talking about during the pandemic, Vacuna Gate, public officials during the pandemic vaccinated themselves, you know all those stories. Among others, the private sector using their power in the market, selling drugs at high rocketing prices and everything. So we need, as a society, more ethics. Unfortunately, do not forget about social justice. When we started in Peru the vaccination against COVID, in February, between January and February 2021, it was quite a success. It was quite a success. You remember me, the times when we were vaccinated against polio, sarampion, America Latina, champion of vaccination. It was beautiful. 1 year and a half after we started vaccinating by COVID, the vaccine reached the native communities in the jungle. 1 year and a half after. And not because of lack of money, lack of political will. Those are left behind always. So my 4 lessons that I would like to share are those: more and stronger state, or ethics, the role of evidence, and fourthly, do not forget about those who are always left behind.
Systematically. Those are great lessons to end on. We have a few minutes, so I'd love to invite some questions. Joya?
You want to start with the...
Oh, yeah, sure. Let's start online, Princess.
So we have one question online, and they asked, given the care system strengthening strategies presented under Inter-American Development Bank's IDB Cares initiative, how do you see these reforms contributing concretely to improved pandemic preparedness and response capacity in Latin America and the Caribbean?
Maybe Claudia, that's for you.
Oh, yeah.
I was thinking it was more a question for you.
The Inter-American Development Bank play a very, very important role in the implementation of the Colombian health reform for 20 years. With the pandemic, I don't know.
Me neither.
What happened after that?
Me neither.
I'm actually, honestly, I'm not familiar with the details of the strategy, so that's what I prefer to refrain to comment on it.
Well, no, in my case, I think they are approaching the right agenda. Because what we have said already, we have advanced in terms of financing coverage, some more, some less, but we have moved from what we had before. But having legal status or having a health insurance, it has to be accepted. And it has to be accepted at the primary healthcare level with health networks. So I think the IDB is targeting rightly, to strengthen the capacities of the state at the basic level with health networks of care, which is from my perspective, is the right way to start this long road.
Muchísimas gracias. Trabajo en Perú con socios en salud.
Okay.
Me gusta mucho Perú. My question is, I think Latin America, in a very different way than Africa, has just very, very profound economic inequality. And how do you think of this economic inequality as a driver for some of these health outcomes? And I particularly reflecting on the real devastating consequences of COVID-19 in Peru, and how much of that do you think is driven by economic inequality, and how does the health sector work across Latin America to try to address that disconnect?
May I?
Yeah, please.
I wouldn't say that it's only economic inequality, it's also social inequalities. It's a mix of social and economic inequalities. And I must say, one of the best evidence that we have from a health financing point of view is that in terms of financial protection, the latest numbers that were published on the Global Monitoring Report that monitors all the SDG indicators and the 3.82 indicator specifically on financial protection that was revised. Some of the evidence shows that the poorest households are those who face the largest financial difficulties in terms of financial hardship as it is defined by the financial protection indicator. The majority of households with excessive or catastrophic spending became impoverished. There's also an ample variability in terms of the number of households that suffer of financial hardship for having to access health services, and it goes from 3 to 35 out of 100 households. So there is a lot of room for improvement and a lot of policy design that needs to be applied in the region. And this is, as I was trying to portray from the beginning on your question, it is a reflection of the inequalities, let alone the people that do not access the services, because you measure financial protection when the people access the health services, but we don't know who don't have access to the health services. So I think that's, and the other, I think there's another piece of information that is very important, is that mostly households fall into catastrophic health spending or excessive spending as it was redefined because of medicines. That's the main cause of catastrophic health expenditure. So, and we haven't resolved the issue yet. If we observe the out-of-pocket expenditure indicator by itself, which is kind of the cost of financial protection, you will see that the trend, it's starting to spike up again after the pandemic, unfortunately. And everything has been treated or tried. But
do you have any last comments on that?
Well, very brief. I think we are measured wrongly in terms of our development. I'm saying this because Peru is considered not only because of its food, but also because in economic terms, we are considered the star of the region. You know, low inflation, low fiscal debt, and the final one, I don't remember, but there is a third one. It's a financial indicator. Growth. Growth. Yeah, the most important one. Economic growth. The three of them, check. Very good. 30% of the people living below the line of poverty, and extreme poverty, and sleeping tonight without proper nutrition. So, food insecurity. I think our status of health is wrongly measured in economic and financial and social terms. And the indicators that we use on health are not sufficient to have the entire picture. And secondly, in terms of social protection, financial protection, going back to your question, PAHO and IDB should stress the need of supporting supranationally, internationally, public goods. Yes. Public goods. That was one of the key management lessons out of the pandemic. The need of an infrastructure that supports the country for public goods and to provide at least a responsive state during an emergency. Even responsive, not preparedness, proper response to an emergency. It could take hours, but those are the two things I would like to share with you.
So I would love for all of you to join me in thanking you, our incredible panelists.
Thank you very much to our panelists. They really showed us how a region with significant challenges can really also provide significant lessons for others around the world facing common problems. We reached the final moments of our event today, so I'm very delighted to introduce Dean George Daly, who will provide some final reflections for us as we close the symposium. Dr. George Daly is the Dean and Caroline Shields Walker Professor of Medicine at the Harvard Medical School. Dean Daly is a world-renowned physician-scientist whose leadership has shaped the landscape of cancer biology and stem cell science. Dean Daly's career has spanned the most prestigious institutions in our community, with leadership roles across Harvard and MIT, Boston Children's Hospital, the Massachusetts General System, and the Brigham Women's Hospital. But more than that, he has been a tireless advocate for the very cross-disciplinary conversations and collaborations that we have seen in the stage today. Dean Daly, we're very happy to have you here, so please, the podium is yours. Thank you.
So I just spent the last hour with Dr. Hanan Balki, who is the RD for the Eastern Mediterranean region of the WHO. And we spoke a lot about the common interests and common mission that we have. The Harvard Medical School is the anchor of a 17-institution consortium, the Massachusetts CPR, which is our pandemic preparedness enterprise. And obviously there's tremendous interest in ongoing pandemic surveillance at WHO. What better organization to do that? We also talked a lot about biosecurity, which has become a new interest of mine through programs at the Harvard Kennedy School, where several of the members of the Biden administration, the national security apparatus, are now working and carrying the ongoing importance of that mission at a time when much of the internal structures for biosecurity and pandemic surveillance and the overlaps of those two have been dismantled. So I am here, and I respectfully apologize for parachuting in at this last minute. I would have much preferred to have actually spent the entire day being here and being educated and enriched by all of the commentary today. But I'm here really as an expression of the solidarity and the deep respect that I have for all that you do. So I appreciate being given the opportunity to make some closing comments. So who did I miss? I missed Dick Chalma. I missed Dick. I missed Dina Bebe. I missed a whole bunch of you, and I'm sorry for that. But I am proud of the fact that under Louise's tremendous leadership of the Harvard Global Health Institute, that we can continue to convene the most brilliant minds from around the globe around such important topics. And I'm sure that the chorus of voices that sung today were rich and inspiring. I want to add another voice to the mix, someone who was part of the Harvard community, someone who received a master's in public health from our Harvard T.H. Chan School of Public Health, and that's Bill Foege. And that's a name that maybe already surfaced today, but certainly many of you know as a legend of public health and a former CDC director. And Bill passed away in January at age 89. Now, Bill was a standard bearer for global health innovation. His innovation brought about one of history's most extraordinary examples of collective action. And the story here, I think, is an important one as we face the rise of vaccine hesitancy in the United States. So it was in the 1960s when Bill and his colleagues working in rural Nigeria were struggling to control smallpox outbreaks. And they had limited supplies of vaccines, and so they got creative. But they got creative in an evidence-based way, and you will know this better than I, but instead of aiming for mass vaccination, they decided to focus their efforts on rapidly identifying smallpox cases and then surrounding them with rings of immunity, the whole strategy of ring vaccination. And of course, that has become the mainstay of the World Health Organization's smallpox eradication campaign. And as Bill wrote, the world's last known smallpox case was apparently that of a cook in Somalia in 1978. It was 2 years later that the WHO declared smallpox officially eliminated. And today, we live in an unspoken and underappreciated reality that smallpox is a thing of the past. Those of us who maintain the interest in biosecurity hope that that statement is indeed true. Now, for Bill and his team, it was a limitation that forced innovation, and innovation opened that door to possibility. And from there, possibility morphed into a plan to actually finish the job, and that was then fueled by collective action, global collective action. Now, Bill was once quoted as saying that smallpox eradication was not an accident. It was the result of a plan conceived and implemented on purpose by people. Now, indeed, that limitation which spurred innovation, which led to possibility, which ignited a worldwide plan, it might seem that that's sort of a vast expanse, but those steps happened. They happened in quick succession, and it took an idea, it took energy, and it took a plan. Now, global health has faced an onslaught of difficulties in the past year. I empathize tremendously with so much of what has been lost. And I heard of that so much from Dr. Balke. Lives lost, opportunities lost, cuts in U.S. international aid funds, new award structures from the National Institutes of Health. As you all know, these have massively altered the calculus of how world public health gets done, gets supported, gets implemented. So it's limitations again. Limitations that are going to drive and have to drive innovation. It seems that the limitations are infinite. They're coming at us from all sides. But it's solidarity that is of quantifiable benefit. We know that when we come together, we can measure the benefit. So I just want to repeat that I am deeply proud to be engaged with the Harvard Global Health Institute. I am a member of the executive committee. I'm deeply grateful to all of you for coming today to nurture a sense of solidarity. Solidarity is what it is what we all need to have to be able to innovate and to catalyze collective action for the benefit of humanity worldwide. And that is the charge of the Global Health Institute, and it's what the world desperately needs. Now, there's another revolution underway, and That is the revolution of AI. And I think we're focused a lot on AI-enabled drug discovery. And I actually hope, and there is a lot of collective hope, that AI is going to be a force that is going to democratize drug discovery and provide innovation that could really transform global health. In our community, there has been a cure, and I use the term boldly, there's been a cure developed for sickle cell anemia. But it involves an extraordinarily heroic and expensive ex vivo gene modification. But innovation in the form of in vivo delivery of the gene editing cargo, equivalent to a one and done single shot vaccination, that's the innovation that we need to democratize that kind of intervention across sub-Saharan Africa where it's needed most. I can tell you that folks here at Harvard and many outstanding scientists around the globe are working towards that innovation. I think one of the things that we're going to have to realize, because we are also here in the United States reeling under a new relationship between academia and our government. We hope that distancing of the relationship is a transient one, but who knows. What's that is meaning, though, is that it's driving us to look towards new partners, and we look increasingly to partner with industry. In the past, academia, we've always had a sort of haughty approach where we'd go to our pharmaceutical partners and we'd tell them all about our latest, greatest science, and we'd say, oh, what do you want to fund? Well, we take a different tack now. We're actually partnering with industry in a way where we ask them what are their challenges. Because we have such an extraordinary, broad, and diverse community that no matter what challenges they have, we can coordinate and convene a pool of scientists who can address those challenges. And so what we're doing now is forging new partnerships that involve co-conceiving and co-executing on some of these great challenges, and we do think that this is going to lead to new treatments. So I hope that that also has some resonance for the kinds of challenges that we're facing in global health. So everyone has got to be also thinking about the way that highly innovative new medicines, especially the GLP-1 agonists, are on the one hand offering tremendous benefit in metabolic and cardiovascular disease, but on the other hand, upending the insurance markets across much of US and Europe. But in fact, the semaglutide patent recently expired. Thankfully, patents expire. And Indian drug makers are jumping in to create generics. And so I know it takes time, but revolutions happen, and ultimately we expect those revolutionary treatments to be globally distributed. I would say we shouldn't always have to wait, though, for the patents to expire. The field of global health has to be bringing more of energy around equitable access to therapies through any number of channels, and it's one of the reasons why we are involved in policy advocacy as well. So I've just spoken about a few of the innovations, but I want my core theme to be that we are one small planet. You know, the astronauts that flew on Artemis II talked about looking back on that small spaceship Earth. We are here all together. It is one globe. We are one global health community. And so I want to just congratulate all of you and thank you for coming together in defense of the better health for all. So thank you very much. I'll turn it back over to Louise.
Thank you so much, Dean Daly. There's nothing that I would like to add to that in closing. I just want to share a number of thanks. I would like to thank the Harvard Global Health Institute team who put together really masterfully this lovely day for us and helped all of our visitors with their travel. I would like to thank all of you who were speakers or moderators, all of our audience members. I'm really grateful to our partners across Harvard, Harvard Law School, Harvard Medical School, Harvard School of Public Health, and the David Rockefeller Center for Latin American Studies for partnering with us today. That means a lot to us. And I'm very grateful to Harvard University and to the Office of the President and Provost for supporting Harvard Global Health Institute and allowing us to convene such a lovely day today. So with that, I will close up the session. For those of you who are online, thank you so much for bearing with us, and we'll say goodbye. And for those who are with us here in person, we invite you to a short reception where we can continue some of the conversations. Thank you so much, everybody. Have a good evening.